Okay, so welcome to another module. In this module, we're going to discuss medications for anxiety, sleep disorders, antidepressants, some anesthetic medications, and finally, uh, an assortment of medications that we use for seizures. There's a lot of information in this module. I hope this helps clarify it for you and allows you to review the book that you use for this particular course. So let's get started with this module. Okay, so let's separate them a bit, and we'll just talk about anxiety disorders. And these are some common symptoms that patients suffer when they have an anxiety disorder. So remember, so it's an emotional state of being, anxiety, that has physiological effects as well. So I'll give you, let's go through these and I'll try and clarify that. So apprehension. So the feeling of apprehension or being almost like being on guard or thinking that something terrible is going to happen. So worry, fear, dread. So a physiological manifestation of that can be a rapid heart rate or shortness of breath, the sensation of shortness of breath. Sometimes patients are hypertensive, and the reason for that is when you're in an agitated state, uh, you're often releasing larger amounts of epinephrine and norepinephrine from your adrenal glands into the bloodstream, and it's ramping up that sensation or that feeling of anxiety, but it's also having the physiological effects of tachycardia, shortness of breath, and hypertension. The pounding in the ears, again, that's from that powerful pounding of the heart because of the excess catecholamines in the bloodstream, which are epinephrine and norepinephrine. Excessive sweating. Again, same thing. It's the secretion of the catecholamines into the bloodstream. Sometimes patients have dry mouth with anxiety disorders, and definitely insomnia or sleeplessness is often associated with agitation or anxiety, since being in an anxious state throughout the day doesn't lend well to falling asleep at night. So it's an uncomfortable condition to have because you're always sensing this background fear and dread and apprehension with the physiological effects that it's causing as well. So it's hard to concentrate, say to study or to work, and you're tired because of the insomnia it's causing. So it's a difficult condition to have. And luckily, there's very effective treatments for it. And we'll go over some of the drug treatments, but remember, one of the most important things patients can receive is counseling, right? Figuring out ways to manage their anxiety and figuring out maybe some causes of their anxiety that can be discovered through ongoing counseling. So it's always a combination of counseling therapy, sometimes meditation, relaxation techniques can be extremely effective, and then medication can also help with some of the symptoms. So it's really never medication by themselves. Okay, so combination for anxiety and depressive symptoms or disorders as well. Okay, so let's just review some specific anxiety disorder categories. So the first one is generalized anxiety disorder. This is extremely common in the general population, and it's typically the feeling of daily anxiety that just feels uncontrollable. So it's excessive worrying about the day, whether it's work, health, it can be financial, it can be fear of getting sick, relationship fears, and they're excessive. So because they're excessive, they're generating a lot of anxiety symptoms within the body. So patients are often agitated, restless, difficulty sleeping, irritable. They can be they can tremble through the day. And often with any of these disorders, by the way, often people will medicate, they'll self-medicate themselves prior to seeing a healthcare professional um, with either sedatives or alcohol just to help their symptoms. Okay, so the next one we'll talk about is another category of anxiety disorders, and that is panic disorder. And really this is the main characteristic of this is recurrent periods of intense anxiety and fear. And usually this is associated with tachycardia, racing heart, palpitations, really sweaty, uh, they're tremulous, short of breath, and they come in episodes and then settle down. So they can last just minutes, and then they settle down. But they're very, very upsetting to the patient because they really feel out of control with this sudden onset of extreme panic. All right, so the next one, social anxiety disorder, or also social phobia, is an anxiety disorder that's related to social settings, right? So the anxiety that starts, say, with say going to a gathering or having to interact with groups of people. Sometimes it's attending school. Um, so it's the fear of social interactions. Okay, so the next one, obsessive compulsive disorder. So obsessiveness is a term where the patient is repeatedly thinking of a certain behavior. So they're obsessing in their mind about certain thoughts. The compulsion is the routine or the action they're going to take to try and relieve some of the anxiety that's occurring due to the obsessive thinking. All right, so let me give you an example of obsessive compulsive disorder. So somebody who has recurring thoughts of cleanliness and fear of infection or dirt can relieve their obsession with compulsive hand washing. Okay, so it's a very upsetting disorder, anxiety disorder to have because the obsessive thoughts really make the patient um, uh, perform certain compulsive actions in order to um, relieve some of the anxiety they have. So it can be related to cleanliness. It can be related to security, say for example, um, having to check the doors over and over and over again because they're obsessing about security of their house or security of their car. Um, it can be obsessing about the weather, checking recurrently about the weather, and the compulsion could be going online and frequently checking the weather report. So the obsessive part is in the brain, the compulsive part is the action they take to try and relieve the anxiety. And you can imagine how this impacts somebody's life by having these obsessive and compulsive action or thoughts and actions throughout the whole day. Okay, so definitely an anxiety disorder. And remember, all of these are very common. These are not rare disorders. Okay, and lastly, post-traumatic stress disorder. It's typically following a traumatic event to the patient. Now, if you have 10 patients or 10 people that are exposed to the same event, the same traumatic event, does it mean that they're all going to develop post-traumatic stress disorder? No, definitely not. So it's dependent also on the individual person, right? So it could be related to having gone to war. It could be related to having been attacked by somebody. It could be a car accident. It may be related to child abuse earlier in life. And typically the symptoms or thoughts are related to uh, the event that's happened in the past, and it can lead to recurrent thoughts, very disturbing thoughts about the event, uh, very disturbing dreams. Patients can have severe insomnia, sleeplessness from this. And usually there's some attempt to avoid anything related to the trauma that they've experienced in the past, partly because they get intense symptoms when their mind starts to approach the painful experience that happened to them. Okay, so let's look at some anxiety disorder treatment options. And it's broken up into anxiolytics, which are for anxiety, and antidepressants, which are for depression. But remember, there's a lot of crossover here between these groups. So when you see that on the prototype drugs later on, don't be confused because we do use some antidepressants for anxiety because they have anti-anxiety effects. Okay? So yes, it's broken up this way, but we definitely use many of the medications in one category, such as antidepressants, in the anti-anxiety section. So, and we'll see that later. Just as we go to each one, we'll talk about that. So, what about just straight anxiolytics? So, medications that have sedative effects directly. And that would be on the left here, benzodiazepines. So these are sedatives, right? So they affect a system in the brain called the GABA system, and that part of the nervous system is an inhibitory system, meaning when you stimulate the inhibitory system called GABA, then you get relaxation, sedation. So gamma aminobutyric acid is a neurotransmitter. That system has relaxation effects in the brain, and benzodiazepines directly stimulate that system. Okay, so alprazolam, which is Xanax, lorazepam, which is Ativan, diazepam, which is Valium, uh, are all benzodiazepines. Notice they all end in lam or pam. Okay, so that's a good suffix to remember. Now, because they have such sedating qualities, these drugs, sure, they're used for anxiety. They're used preoperatively to sedate patients or to calm them. They're used for sedations to put people to sleep, so procedural sedation. We will use benzodiazepines to heavily sedate someone if we're trying to do a procedure. So they have a number of indications. We use them for insomnia, for patients that have real difficulty sleeping. We'll use one of the benzodiazepines. So multiple uses that we'll come to. The other group in the anxiolytics is the azapirones, and really the only one in this group. There's many other, but they all have the same ending. So pyrone. So buspirone or buspirone is by far the most common one that's used for anxiety, and in particular, it's used for generalized anxiety disorder. Okay, it hasn't shown to be very effective in the other ones, but definitely in generalized anxiety disorder, it's used. Okay, so now let's go to the other side, the antidepressants. So we have selective serotonin reuptake inhibitors. So what do? They block the reuptake of serotonin back into the nerve. So higher levels of serotonin in the synapse. Serotonin is associated with improvement. So elevated serotonin levels is associated with elevated mood and improved mood. So in a bit of a basic way, we'll get into it a bit more. These SSRIs, which are by far the most common on the market for depression, the SSRIs and the SNRIs are by far the most common group for depression currently. So we'll go through some of those. Citalopram, paroxetine, sertraline. They're all selective serotonin reuptake inhibitors. Okay, and that's just a fancy way. That's the group they're in. That's just a fancy way of saying more serotonin in the synapse, in the synapses of the brain. So elevated serotonin levels. Okay, what about SNRI? So selective norepinephrine reuptake inhibitor. So the one in this group is going to be venlafaxine, and the brand name for that is Effexor. And this one not only increases serotonin a bit, but it also increases norepinephrine. So it's in a slightly different category. It's used very commonly as well. It's in selective norepinephrine reuptake inhibitor. Tricyclic antidepressants on the bottom left there. There's many of these. Amitriptyline, imipramine. There's a whole bunch of them, and they're older. They're a generation ago, and we don't use them as much for depression because they had potential for high toxicity in overdoses. And depressed patients can become suicidal and consume or overdose on their medications, and a TCA overdose can be very, very serious. So the SSRIs and the SNRIs are much safer medications in overdoses. They can definitely cause symptoms that we'll get to, but they're not as dangerous as TCAs in terms of taking an overdose. Okay, so tricyclic antidepressants, and we'll talk a bit about those. And lastly, 2 generations ago. So we spoke about the two groups that are current. We spoke about TCAs that are kind of 1 generation ago. And now let's go 2 generations ago, the MAOI inhibitors. So in this group, we'll see. So what are MAOI inhibitors? Sorry, monoamine oxidase inhibitors. These have a lot of side effects. and a lot of interactions that we'll come to. So when the TCAs came out, we were very happy to move on away from the MAOI inhibitors. Okay, and they're still used for resistant depression, but they're not really mainstream medications anymore. So you won't see them, you won't see these as commonly. Mirtazapine, that's an antidepressant that's used. That's in its own group, so that's why it's listed under others here. And we'll talk a bit about those. But now you know really the main groups: SSRIs, SNRIs, TCAs, and MAOI inhibitors. Okay, so what are benzodiazepines? So we know that they're for anxiety. We can use them for insomnia. They're actually first line drugs to give a patient that comes in with acute seizures that won't stop. So we'll use them in the emergency room to stop a seizure, typically either intramuscularly or intravenously. And they're also used, as I mentioned, for pre-op sedation or procedural sedation to put someone to sleep for a period of time while you're doing a procedure. So very, very commonly used group of medications. So they definitely have, uh, as I mentioned, relaxation effects on the muscles. So everything is dose dependent, right? So if you give a small dose of a benzodiazepine, you'll relax someone, you'll you'll make them feel less agitated. Um, you can you'll notice that by, say, if you're giving it for anxiety, reduced heart rate, reduced blood pressure. But as the dose gets greater and greater and greater, what's going to happen? Well, you're going to potentially really sedate them to the point of sleeping. You can drop their blood pressure. You can impact their respirations, so slowing down of respirations. So a benzodiazepine overdose, how will it present? Well, it's going to present with um, extreme sedation or unconsciousness, um, very slow or absent respirations, low blood pressure, and this can happen. So we can do it sometimes in the hospital by just giving too much and over sedating someone, or it can happen by someone taking an overdose of their benzodiazepines. So really a benzodiazepine overdose becomes an airway issue as number one. So always think of airway if you're being asked or you're seeing someone who has a benzodiazepine overdose. Now, we also have a reversal agent that we can inject into someone um, that reverses a benzodiazepine overdose by blocking the benzodiazepine on its receptor in the GABA system, and that's called flumazenil. And we'll talk about that later, so don't worry about it for now. So just know that we have a reversal agent for benzodiazepines. So these are commonly used drugs. You're definitely going to see them. And as I mentioned, patients are frequently on them for anxiety. Unfortunately, they have addictive properties. So staying on benzodiazepines for months and months and months will lead to dependence and very difficult to wean off benzodiazepines. So a patient that presents with taking a benzodiazepine, you definitely couldn't just stop it suddenly. What's going to happen? Well, they're going to become acutely agitated, tremulous, um, because they've been on a sedative for so long, tachycardic, and in severe cases, they're going to go on to have seizures because you've removed the inhibitory drug from their system, and the brain is waking up and becoming highly agitated to the point of seizures. Okay? In elderly patients, benzodiazepines have become a bit of a drug to avoid because they get um, very sedated on them. Patients are left on them for years, and they are at much higher risk of injuries and falls while being sedated on a benzodiazepine. So dependence is an issue at any age, right? So if you're 20 and you're on, say, diazepam or alprazolam, sure, if you're on it chronically, it's 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 going to be hard to get off it because of the dependence. And if you do go off it, it has to be weaned off slowly. So you need to be titrated off the benzodiazepine slowly to avoid what I just spoke about in terms of agitation and seizures and all those withdrawal effects. Okay, so so we do try to use other medications uh, that don't have such dependence like the benzodiazepines do, but they are extremely effective medications to help anxiety today. Like they work today, right? So someone who comes into the hospital highly agitated, we can use benzodiazepines to really calm them down in the moment, as opposed to some drugs that we'll talk about can take many, many weeks to start to take effect. So let's start with a benzodiazepine. And remember, all of them in this group basically do the same actions. They have the same side effects. They have the same adverse effects, and the nursing considerations are very similar. Okay, so whether we're talking about alprazolam or diazepam, lorazepam, they're all very similar. And notice that the endings of most of them are either going to be lam or pam. Okay, so diazepam, lorazepam, alprazolam. Okay, for the most part. And those are the common ones for sure. So the therapeutic class, they're sedatives. Okay, so they're they will sedate someone. They're hypnotics, meaning they will induce sleep. So they're used as sleeping pills. And they're anxiolytics. They will help anxiety very, very quickly. Within half an hour to an hour, people are much more relaxed with acute anxiety. Okay, so what are the indications for benzodiazepines as a group? Well, for acute stress disorders, so any of those anxiety disorders that we saw, but also acute stress. Someone's been, say, in a car accident and they're acutely agitated. Or there's been a sudden uh, anxiety-provoking event, like a death in the family, and someone just can't get on top of the anxiety and the distress they're in. And you'll see the other ones, post-traumatic stress disorder. Uh, as I said, we use these intravenously or intramuscularly for someone who continues to have a seizure in order to stop the seizure. Insomnia, so as a sleeping pill. Acute muscle spasms. So if someone comes in and they have acute muscle spasms of their back, we can use a benzodiazepine to try and stop it. We also use these for someone who's withdrawing from alcohol. They're agitated, they're tremulous, they're sweaty, they can become delirious, confused, and we'll use diazepam or lorazepam, or the third one you see, chlordiazepoxide. That has a strange ending, but that's also a benzodiazepine that we could use for, say, alcohol withdrawal. For putting someone to sleep for anesthesia. It's often started with a benzodiazepine, so induction of anesthesia. Amnesia, so loss of memory or lack of memory to the event prior to a surgery, or a procedural sedation, such as somebody needs an abscess drained, which is going to be very painful. So sometimes we'll sedate them with a benzodiazepine and give them a painkiller, both intravenously, so that they don't have a memory of the event at all. So what are the actions of, how do they work? Well, they stimulate an inhibitory system called gamma aminobutyric acid, which is a neurotransmitter in the brain, and it's an inhibitory system. So by stimulating an inhibitory system, you're actually sedating the brain. Okay? What are the main side effects or adverse effects? Well, gastrointestinal upset won't be the concerning side effect at all. CNS depression will be though. So CNS depression of decreased level of consciousness. This will lead to reduced respiratory drive, decreased respirations that can lead to reduced oxygen saturations. They can also cause, in higher doses, hypotension, so low blood pressure from large doses of benzodiazepine. But definitely you have to think of CNS depression and respiratory depression. Do they have amnestic qualities, meaning you don't remember the event? Yeah, definitely. If we give enough doses, patients will have amnesia to the event. Rarely, especially in children, they can actually have a paradoxical response, meaning we give them benzodiazepines to sedate them, say for a procedure, but they have a paradoxical response, meaning it agitates them even more. And children can have this paradoxical response not only to benzodiazepines, sometimes when we give them, say, diphenhydramine, which is for allergies, but it also has sedative qualities. Sometimes that can cause a paradoxical response in children. And of course, withdrawal effects. So a patient runs out of their alprazolam or their diazepam, and suddenly they're going to go into acute benzodiazepine withdrawal, which is going to be agitation, tremulousness, nervousness, tachycardia, sweating, and even potentially a seizure. Contraindications, well, we definitely try very hard not to give this to pregnant women. It not only is it habit forming, so dependence, but not a good idea for the fetus to have benzodiazepines flowing through its bloodstream. And also, pregnant women tend to require more respiratory effort. They're bringing in oxygen for themselves and for the fetus, so they tend to have higher oxygen requirements. So benzodiazepines suppress respirations as the dose gets higher, so not a good idea. Sleep apnea. So someone who has sleep apnea, uh, especially obstructive sleep apnea, meaning when you go to sleep, your neck muscles relax so much that you occlude your airway while you're sleeping, and you have periods of apnea where you're not breathing. So giving someone who has a history of sleep apnea benzodiazepines for sleeping is not a good idea, since it's going to relax the neck muscles even further, causing more episodes of apnea. And respiratory depression. Well, we already spoke about that. So someone who's already respiratory depressed, so they come into the hospital and they have a condition where they're having difficulty breathing, or they're breathing very slowly, say from an opioid overdose. Uh, we would never give someone in respiratory distress or respiratory depression a benzodiazepine. It's just going to aggravate the breathing situation since it depresses breathing even further. Glaucoma, I won't get into. Patients often have glaucoma. That wouldn't be a big contraindication. The other ones I would consider more important. Okay, so let's talk about a bit of nursing considerations with benzodiazepines. So it's a Schedule 4 medication on on the schedule list for controlled substances. So relatively, quite low down, considering that it has dependence issues associated with it. In terms of toxicity, let's just talk about someone who's taking too much oral benzodiazepines first. So what are they going to be like? So someone who takes too much of their lorazepam or their diazepam, they're going to be sedated, lethargic, confused. And if they take large enough amounts, even orally, they will start to run into trouble with their breathing and their level of consciousness even further, and potentially hypotension. Now, this is has a more uh, it's more concerning in terms of IV dosing. So intravenous benzodiazepines, which we use all the time, can definitely lead to acute respiratory depression if given in high enough doses, low blood pressure, and finally, this would be unusual though, since they're being monitored when we're giving them intravenous benzodiazepines for sedation, but they can have a cardiac arrest if not be if not if the monitoring is not appropriate. So they're drugs that you have to be careful with when giving intravenously for sure. Okay. So what about the treatment in terms of toxicity or an overdose? So if it's an oral overdose, they can receive, and this is very common, to receive activated charcoal to try and stop. So charcoal we use all the time to try and stop drugs from being absorbed to begin with. So if they come in early enough, we can give them oral charcoal solution to absorb the benzodiazepine and even stop it from being absorbed through the gastrointestinal tract. Gastric lavage is where we just put large amounts of of, uh, of saline and laxatives, so it just forces it to flow out the other end. That would be less common. We would, if they came in early enough, within a few hours, we would give them charcoal. Now, there's one thing to remember always with using charcoal for any overdose. We never ever give charcoal if the patient has reduced level of consciousness. Okay, so important to remember that. Why don't we give patients charcoal if they have a reduced level of consciousness? Because if they aspirate it, if they vomit, and charcoal goes into their lungs, that is a huge issue. That's going to set up serious consequences and respiratory distress from the charcoal aspiration. So they have to be cooperative and awake to receive charcoal for any drug overdose. So patients with benzodiazepines often have reduced level of consciousness. So we don't always use charcoal, and sometimes we'll just go right to the antidote, which is flumazenil. And this will completely reverse the effects of the benzodiazepine in the body. So for an acute overdose, so say someone takes 100 lorazepams and they're basically unconscious and they're not breathing for themselves and they're hypotensive, we can give them an intravenous dose of flumazenil. And definitely always monitoring airway, breathing, and circulation is key. Okay. Now I'll just finish with flumazenil, which is the antidote for a benzodiazepine overdose. If someone's taking benzodiazepines chronically for anxiety, and they come in and they've taken too much, so they're sedated, maybe their respirations are a bit reduced, giving them flumazenil is going to completely reverse the effects of benzodiazepine. So what you're going to now get is a patient who is in acute withdrawal because they've been on the benzodiazepine long enough that you've now just reversed it with the intravenous flumazenil. So really, we reserve flumazenil for patients that are quite unstable in terms of not breathing for themselves, fully unconscious, and are hypotensive with the benzodiazepine overdose. Okay, so if they're a bit sedated and they seem to be breathing slower, but they're still stable, we don't always go for flumazenil. We'll observe them and let the benzodiazepine wear off. Okay, so these drugs are typically used for short-term due to dependency, which will make it very hard for patients to stop the benzodiazepine, and they'll go into withdrawal symptoms when it is stopped. So, if someone is on it for a long time, we can gradually reduce the dose to offset those withdrawal symptoms, but typically it's meant for short-term use. Avoiding grapefruit juice, that's just, as a whole, the whole group, benzodiazepines happen to interact with grapefruit juice, which can elevate the levels of benzodiazepines in the bloodstream. At some point in this whole course, we'll just make a list of all the drugs that interact with benzodiazepines, with grapefruit juice, since it's hard to recall each particular group of drugs and this grapefruit juice interaction. Okay, and we're almost finished here. Avoiding other CNS depressants. So combining benzodiazepines with alcohol, opioids, barbiturates they're going to have additive effects of sedation and respiratory depression. So that can be dangerous for sure. Avoiding activities where you can be injured. So driving, going up on ladders, heavy machinery operation. That can be dangerous while on benzodiazepines. Okay? And the the other thing just to remember that when you're on an oral benzodiazepine is not to chew them or to crush them uh, when you're taking them. It's going to cause a much faster effect of the benzodiazepine. So avoiding chewing, especially any sustained release tablets, is always a good idea to avoid breaking them or chewing them. Okay, so the next drug is diazepam. I will not need to spend as much time on this slide because it's basically another benzodiazepine, right? So we don't need to spend 15, 16 minutes on really the same type of, it's just a different drug in the same group, right? So the indications are going to be the same, the action will be the same, the adverse effects are going to be very similar. The contraindications, they look the same, right? All benzodiazepines try to avoid with breastfeeding. Definitely prescribing these to someone with a history of any substance abuse is a bad idea because it will uh, not only be dangerous to them, since they're probably abusing alcohol and other drugs, but a, a patient with addictive qualities, you're going to make it very difficult for them to get off of these drugs. Okay, severe liver or kidney disease would be a contraindication, or we would try to avoid benzodiazepines because that's how they're metabolized and excreted. And another thing to remember is old people. So old people on benzodiazepines get confused. They have falls. They break their hip. They lie in bed after they break their hip. They get bed ulcers. So we try to avoid these in elderly people as much as possible. Okay. Under nursing care, um, there, there's the statement for older patients: reducing the dose, avoiding alcohol and other sedatives such as barbiturates and opioids. And there are many people on opioids for pain. Barbiturates are far less common. We still use them sometimes for for resistant seizures, but they're much less commonly seen. Someone who needs to get off of a benzodiazepine that's been on it for months or years, a very gradual tapering of the dose over weeks to months is required. Okay? And if you're using it as a hypnotic for insomnia, it's usually 15 to 20 minutes prior to bedtime. And we try to limit these medications to a week or two, but it's not possible in some patients. Some patients just require um, the use of benzodiazepines for their chronic agitation, anxiety, or sleeplessness. So let's look at the other group of anxiolytics, medications for anxiety. And the prototype really for this one is buspirone. And really it's the only one in this group that's frequently used for anxiety. And you can see some of the indications for it. So this is not a benzodiazepine. We spent some time on those. This medication does not work immediately like benzodiazepines. It can take up to a week to even start to work, and often it can take 2, 3, or 4 weeks to be effective in terms of controlling anxiety. And you can see some of the indications for it. They're all those anxiety conditions that we spoke about earlier in this module, whether it's panic disorder, uh, generalized anxiety disorder, post-traumatic stress disorder. So there's a disadvantage to using these medications, or this medication, because it doesn't have immediate effects. Um, and some patients need immediate effects. And the other issue with this drug is that you're taking it every day in order for it to work. So you're not taking it as needed. It's just a regular dosing daily to try and control some anxiety symptoms. So it's not a sedative um, as we think of in terms of the benzodiazepines. We think it works through binding of serotonin and dopamine receptors and increasing serotonin levels in the brain. Okay, so let's look at some of the adverse effects. So most of them will make sense since it's for anxiety. So, and it's going to have a CNS effect. Dizziness, headaches, nausea, lightheadedness can occur with buspirone. Now, this doesn't have the dependence issue that benzodiazepines do. So that is an advantage to this medication for anxiety, that you don't become dependent on it and require titration in an attempt to get off the medication later when it's not required. So the contraindications, we don't need to go into multiple drug interactions. That's always that's for a book to look up. You can't memorize all drug interactions. Sometimes it's important to remember some, but not for this particular medication. So as mentioned before, it can take 2 to 4 weeks to have some anti-anxiety effect. Again, there's that grapefruit juice, avoiding with grapefruit juice, which can cause some elevation of the buspirone, so magnifying its effects. And this group of medications, you're going to see when we're in this module and the next one, that to avoid MAOI antidepressants. So basically, any sedative or any antidepressant that we're going to talk about, the common ones that we're currently using, you would never add an MAOI inhibitor, which is a monoamine oxidase inhibitor antidepressant. These are very, very old drugs, and they don't get along with so many drugs and many, many foods, and we'll get into those. But when you see that, it would be very rare to combine them anyways because they're so rarely used now. But because they have such an effect on the central nervous system, any other drugs in this group, whether it's sedatives or other antidepressants, they will not be, we will not use MAOI inhibitors in combination with them. Okay, so let's just look at some interactions. Again, interactions are typically, you can't memorize all interactions. Erythromycin and ketoconazole. So one's an antibacterial, one's an antifungal. Those two drugs just don't get along with so many drugs. So because they both affect metabolism of many, many, many drugs. So, and buspirone happens to be in that group. So erythromycin and ketoconazole, because they inhibit metabolism in the liver so much to other drugs, you'll often see them as listed not to be used in combination with other drugs. So that's all that's getting at. St. John's wort is an antidepressant. So adding a herbal remedy such as St. John's wort, which has some antidepressant effects, would not be a good idea when you're using a prescription medication such as buspirone, which is already affecting the central nervous system. Okay? So really the advice that you give someone is don't expect immediate effects. It can take 2 to 4 weeks. Tolerance and dependence are not really an issue with this drug as they are with benzodiazepines. Okay, so this slide has been included in the anxiety section as a reminder that we often use medications in these groups for anxiety, but they're actually marketed as antidepressants. Okay, so we'll talk about them more when we're speaking about antidepressants. But remember, anxiety and depression really live together as conditions. So very, very commonly, we will prescribe SSRIs and SNRIs to help with reducing the level of anxiety in a patient. And these medications are taken daily for anxiety control. So because they're they're really antidepressants, we'll talk about them more then, but you have to remember that many patients use them for chronic anxiety. TCAs, I mentioned that they're a bit older, tend not to use them as much for depression or anxiety. Sometimes we'll use a small dose of a tricyclic antidepressant for sleeping because they have powerful sedative qualities. Um, MAOI inhibitors are much older, even more toxic than the TCAs. So these are uncommon drugs to see unless you're uh, resistant to SSRIs or SNRIs as a treatment for depression. But the slide's been added here just to remind you that you will see these drugs used for anxiety as well, especially the SSRIs and the SNRIs. Okay, so anxiety and sleep. Well, we spoke about the fact that anxious patients have difficulty with sleep, that they have insomnia. What's rebound insomnia? Well, that's typically when a patient is on a sedative medication, such as a benzodiazepine, and they suddenly stop it. Uh, so they've been taking it for months, and now they stop it, and they have rebound insomnia. They are unable to fall asleep or remain asleep because the brain essentially has become accustomed to having the drug to help with sleeping. Okay, so there's definitely a physical and a psychological dependence to benzodiazepines. Now, so we spoke about the link between anxiety and insomnia. They often go together, and actually depression and insomnia often go together. And we'll talk about that when we get um, to the slides on depression. So trying to treat daytime anxiety can be beneficial to helping sleep at night. Since you've relaxed the body through the day, nighttime and sleeping uh, can be much improved. So, and remember, it's not just medications, it's meditation, uh, counseling, relaxation. So patients need to make time for those activities as well to try and reduce their anxiety. Okay, so sleep disorders. So insomnia is difficulty sleeping. So that can be difficulty falling asleep or difficulty staying asleep. And if it's primary insomnia, it's really not associated with any other medical condition or a psychiatric condition or related to medications. Sometimes it can just happen, especially as we get older, we can develop insomnia that's really not related to anything else that's happening. Secondary insomnia, again, very common, can be caused by uh, other medications that patients are on, medical disorders, psychiatric disorders, very poor sleep habits, um, computer use late into the night and then trying to fall asleep, uh, stress, caffeine use in the evening, so high consumption of coffee or stimulants uh, that will then impact your ability to fall asleep. And sleep disorders can become a bit of a vicious cycle because if you start to lose significant amounts of sleep, the next day you can be a bit agitated, anxious, irritable, and the next so that night it will be potentially more difficult to fall asleep because the daytime you've been exhausted and agitated and irritable. So it can be a bit of a vicious cycle that needs to be broken sometimes with medications to get patients to get a good night's sleep. Um, and that can require either an ongoing hypnotic medication or just a short course of a hypnotic medication to help with sleeping until they adjust other things in their life that's affecting their sleep. So whether it's their sleep habits and what they're doing in the evening, or whether it's heavy consumption of caffeine beverages, or they're using stimulant drugs that need to be looked at and adjusted or eliminated. All those things can help with sleeping. Okay, so medications for insomnia. So there's four groups. The non-benzodiazepine insomnia medications, benzodiazepines, which we mentioned in the anxiety section, they are definitely used for insomnia. Antidepressants. So here they are showing up as a medication for insomnia, even though they're listed as an antidepressant. And it's because they have anti-anxiety effects as well. And they can help improve anxiety, which can then help with insomnia. Barbiturates are highly habit forming and lead to dependence. They would be much less commonly used for sleeping now compared to 30 or 40 years ago. And then there's non-prescription medications that people try. So sedating antihistamines, such as diphenhydramine, can be used for or attempted for sleeping. And often that can be effective for a few days, but usually the effect wears off. Okay, so this medication is a non-benzodiazepine, so zolpidem. Uh, Trade name is Ambien. This is for short-term use of insomnia. Often short-term use becomes long-term use though, because patients are sleeping better and they're a bit resistant to go off the medication, which makes sense since they're getting a better night's sleep. It has this similar effects in that it affects the GABA system, which is that inhibitory system in the CNS. So if you stimulate an inhibitory system, you relax the patient, you relax the brain, right? So the effects, the adverse effects are daytime sleepiness, right? And that can be with benzodiazepines too as well, daytime sleepiness. Lightheadedness with this as well. So this is a pill that you would take at bedtime to improve your sleeping and help you get to sleep. A Schedule 4 medication, much lower risk of dependence compared to benzodiazepines that we use for sleeping. So it became quite popular as a medication for insomnia. And by the way, this is just used for insomnia, not for anxiety. And it became popular because there was really a move to try and get away from benzodiazepines and all their issues with dependence and potential toxicity when overdosed. Avoiding use of other sedatives, very good idea. So avoiding alcohol will be advised. Avoiding opioids such as morphine or hydromorphone or codeine because it'll have additive sedative effects. So any CNS depressant shouldn't be combined with a medication such as zolpidem because it'll have additive CNS depressant effects. Okay, so another hypnotic medication for sleeping, Ramelteon, definitely not as common as the other medications. And this is a melatonin receptor stimulator. So melatonin is uh, is a is also a medication. Actually, you can buy melatonin at the pharmacy or at herbal stores, and it's often used for insomnia. And this drug has similar effects to melatonin. It is used for chronic insomnia, or can just be tried instead of melatonin for acute insomnia for short periods of time. I mean, this drug really doesn't have any dependence issues or withdrawal issues. So if it's not effective, the patient can just stop it. Okay. It doesn't need to be gradually titrated downwards like benzodiazepines would be. So adverse effects, well, sleepiness, dizziness, fatigue, that makes sense. It's supposed to have sedative qualities. The contraindications, well, can be used in pregnancy. We try to discourage use of medications in pregnancy and, of course, in breastfeeding. Trying to avoid it in any kind of in respiratory depression or patients with apnea or sleep apnea or respiratory conditions such as COPD. And definitely any older patients, we try and discourage anything that can affect their central nervous system since they're much more sensitive. That's not to say that older patients don't have insomnia and we need to try something to help them, but just always considering that we can make an older patient fall and injure themselves very easily with sedative medications. Okay, so this is really just for insomnia. Taken 30 minutes prior to bedtime. Always advice in terms of not driving or, say, climbing on a ladder, something that's risky where you could potentially fall and injure yourself. And I think all you really need to remember for this is that it's similar to melatonin in its effects. Okay, so this is the last slide on anxiety and insomnia. So these drugs, medications are for sleeping. So melatonin we discussed already to induce drowsiness. It would be considered a natural or a herbal remedy that can be very effective for some people. Valerian we spoke about in the herbal remedy module for sleeping and insomnia. And lastly, kava, which has anti-anxiety properties, sedative properties, and can also help with sleep. Okay, so anxiety and insomnia often go together. And just to finish up with this section, remember we can use benzodiazepines for an assortment of reasons. Anxiety is definitely one of them. Sleep is another one. So insomnia, we'll use benzodiazepines. And then we discussed some specific medications like zolpidem for just specifically for sleeping and not for use for daytime anxiety. And lastly, you're going to see in your book that SSRIs and SNRIs are listed for all of the anxiety conditions that we spoke about at the start of this module, and they are extremely common for use in anxiety disorders. We're going to talk about them in the depression part of this module, since they apply as antidepressants, but always remember that we use them very frequently for anxiety. So these drugs have dual purposes, and you'll see that we'll mention that when we get to those specific drugs. So this next part of the module is on depression. Depression is a very common psychiatric illness that affects many, many people. So there's an assortment of medications that are available to try and help patients with depression, along with other modalities such as counseling. There's many modalities that patients will will try for their depression, and not just medications. So there's cognitive behavioral therapy and many other different counseling and therapies that are used in combination with medications. And remember that depression is on the spectrum of mood disorders. So we'll see in the next slide that really depression is is one side of a spectrum of a mood disorder, and the other side will be mania, and we'll talk about that in the next slide. And antidepressants are going to be broken up into groups, right? So I mentioned before that there's SSRIs, so selective serotonin reuptake inhibitors, and their main focus will be to increase serotonin levels in the synapses of the brain to improve certain brain functions that are responsible for the depression. But of course, they're not specific, so they're going to have side effects because they increase serotonin all over the body. And then we have the SNRIs, the selective norepinephrine reuptake inhibitors, followed by tricyclic antidepressants, the TCAs, and then even older group, the monoamine oxidase inhibitors. And we'll talk about each group. Okay, so here's the spectrum of mood disorders, and we're going to be talking about depressive disorders, right? So dysthymia just means someone who's chronically in just a mildly low mood all the time. They're dysthymic. And then it goes from mild, moderate, severe depression all the way to severe depression with psychosis. So they're so depressed that they can hallucinate. They can have delusions. When we go the other way, we're going to go to higher levels of mood, so more on the manic side. So elation, hypomanic, meaning you're not quite at the manic stage, but your mood is highly elevated. And then there's mania, where you're extremely your mood is extremely elevated. You're likely making poor decisions in terms of finances and spending. You're completely unable to concentrate. You have pressured speech. Usually patients with mania just can't stop talking. It's just one sentence after the next. And then there's mania with psychosis. So they're so manic that they're actually either hallucinating or delusional. And you'll see that there's cyclothymia, which someone will just oscillate from dysthymia, which is just a low mood, and then back to a slightly elevated mood, and then back to low mood, and they'll just cycle there. Compared to a bipolar disorder, where they're cycling, but they're cycling at much more severe depressive side and a much more severe manic side compared to cyclothymia. Or you can just suffer from recurrent depressions, which is also very common. Okay, so in the interest of time, I'm going to leave this slide to you in terms of just some definitions and some just a brief description of major depressive disorder, and I'll move on to the next slide. So this slide is showing you some of the symptoms that patients with depressive disorder often describe. So low energy, often they have sleep disturbances, typically insomnia. They have abnormal eating habits. Many patients lose their appetite. They just don't have an appetite anymore. Some patients can have excessive appetite and actually overeat. So it's something's happened with their eating patterns and their sleep patterns. And then just feelings of hopelessness and despair is common with depression. And then patients can often have thoughts of suicide, and as that progresses, they can have a plan for suicide or even an attempted suicide. So that needs to be assessed when a patient comes in with depressive symptoms, what their level of suicidality is. And often we assess that through discussing if they've had an attempt already, um, have they made a significant plan, have they written a note, or um, have they been found with a firearm at home? All these things will come into an assessment of their suicidal uh, level when they come into a hospital. So postpartum depression uh, can be is quite common. So there's significant shifts in estrogen and progesterone levels that are felt to have an impact on the brain, leading to, we used to call it postpartum blues. There's also a significant change in a new mother's lifestyle and a new stressor that can lead to postpartum depression. So it's very common for women after delivery to have depressive symptoms. Now, postpartum depression has a spectrum in itself. Some women can develop severe depression after delivery, requiring antidepressants. You can actually have postpartum psychosis with a depression, where not only are you depressed, but you can become delusional or hallucinations. Because that's really what when we say psychosis, um, that refers to either having delusions or hallucinations. So there's definitely a relationship between these hormonal shifts. There's a bit of a genetic component to postpartum depression, uh, and just the environmental changes, the significant change in lifestyle that's occurred after delivering a newborn. Okay, so another form of depression, seasonal affective disorder, SAD, common as the number of hours of sunlight reduce, so are reduced. So typically in northern countries, Scandinavian countries, northern U.S., Canada, there can be uh, more people that suffer with seasonal affective disorder. And we think it's associated with changes in melatonin release in the brain itself, since your brain does produce melatonin. And it usually starts in the fall and improves in the spring. And some patients need to go on to antidepressants for seasonal affective disorder. Other patients go for light therapy, so just UV therapy, or just traveling to a southern country as a on a trip can help some patients with seasonal affective disorder. Okay, what about the pathophysiology of depression? Just briefly here. Uh, it's relatively poorly understood. The all the all the factors that lead to depression. Uh, it's felt to be related to neurotransmitters in the brain, such as serotonin, dopamine, and norepinephrine. So that's why these medications you'll often see are trying to elevate serotonin levels and norepinephrine levels, and actually sometimes dopamine levels. So most of the medications are aimed at trying to increase neurotransmitter levels. There's definitely a genetic predisposition. So if you have a family member, a sister, a brother, mother, or father uh, that has depression or anxiety, actually, you would be more predisposed to getting uh, depression. So, for example, twins, so identical twins have a very high chance of both having depressive illness if they have a mother or a father that has depression. So we know there's a very strong genetic link. Stressful life events can trigger a depressive episode. So it can have chemical changes in your brain from the stressful event that's occurred. Medical illnesses, so chronic medical illnesses can lead to depression, which makes sense if you have an ongoing medical illness that can be that can seem very hopeless and lead to chronic depression or a depressive episode. And then there's medications that, as a side effect, has the potential to lead to depression. Um, so we'll avoid certain medications, such as beta blockers. So we haven't spoken about them yet, but I'll just use them as an example. Beta blockers are for high blood pressure and for angina of the heart, but we'll avoid them or try to avoid them in patients with a history of depression since they can aggravate depression. So just an example, but we'll get to those in another module. So this is just a slide on the biologic theory of depression, that it's felt to be related to neurotransmitters in certain parts of your brain, such as the limbic system, which is responsible for mood and emotions. So low levels of norepinephrine, serotonin, and dopamine, and as well the endocrine system. So your thyroid gland. So there can be a relationship between low thyroid levels and a depressive illness. Or your adrenal gland. So if you have adrenal issues and you're underproducing cortisol, it can lead to a depressive illness. So the endocrine system also plays a role. So there's often been a debate on how much depression is related to environmental factors versus genetic factors. And we don't really know the answer to that. We think they both have a role in development of depression in a patient. So we can see that with genetic factors, definitely increased incidence of depression if you have a first degree relative with depression. So that would be your mother, your father, a sibling with with depression. And then of course we've spoken about environmental factors as a cause of depression as well. And that would include childhood events that uh, that have remained unresolved leading to depression in adolescence or in adulthood. So when we're talking about depression treatment or antidepressants, there is definitely no expectation of the medication having an immediate effect because they don't. It can take weeks, and often it can be 4 to 6 weeks before there's an improvement in mood of the patient. So, and initially, especially in adolescents and young adults and children, there's actually a black box warning on antidepressants because it can increase suicidal ideation um, when starting therapy with antidepressants. So, initiation of antidepressants needs ongoing monitoring. Uh, Often you can form a contract with a patient in terms of suicidal ideation that if they feel they're suicidal, they have a place to call or to contact or to follow up. And it's more of a contract saying that, if you're feeling this way, don't just stay at home and endure it. Follow up so something can be done about it. And then there's definitely a requirement for follow-up when someone's starting an antidepressant, not only to see what's happening with their mood, but also to see if they're having adverse effects of the medications, since many of them do have adverse effects that we're going to talk about. Okay, so depression and suicide are definitely very related. So ongoing depressive symptoms or severe depression can lead someone to very strong feelings of hopelessness uh, for the future, and this can lead to suicide attempts. So males tend to have a higher success rate uh, of completing suicide, mainly because they use higher levels of violence to accomplish that. So uh, firearms, for example, one method for um, would be one method that would be higher in males versus females. Females tend to resort to less violent methods for suicidal attempts. They may attempt an overdose of medication with still a suicidal intent, but they tend not to have such violent attempts as males do. So males tend to complete their suicidal intentions more than females. So non-pharmacologic therapies we've spoken about, psychotherapy, which would include cognitive behavioral therapy. And this is very common in patients with mild to moderate depression that may not need an antidepressant, or an antidepressant is used in combination with psychotherapy. So that's very common to have multiple modalities of treatment for depression. Phototherapy we mentioned under for seasonal affective disorder, which is a type of depression related to decreased number of hours of sunlight, and you can actually go and receive artificial lighting, um, or even better, travel somewhere where there's more hours of sunlight in the day. So ECT, electroconvulsive therapy, is still used for serious and unresponsive depression to medications and psychotherapy, and it can still be very effective. So stimulation of the brain with electrodes to, uh, to to create a seizure. Often these patients are medicated so that when they're receiving ECT, their muscles aren't twitching all over the place, and so they're anesthetized and they're given a muscle relaxant so that um, they're not flopping all over the bed with a seizure. But ECT can be very effective for severe depression that's unresponsive to medication. Okay, so with antidepressants for depression, the plan or the aim is to elevate and improve somebody's depressed mood, tends to treat all the symptoms of a major depressive illness. And they're also used in bipolar disorder. So in bipolar disorder, you have a manic phase where your mood is elevated. It's hyper elevated actually. It's manic. And then you have a depressive phase, and antidepressants can be used during a depressive phase. Now, unfortunately, what can happen with in a bipolar disorder is when you use an antidepressant, you can send them into a manic phase. So again, these patients need careful follow-up when they're on antidepressants to make sure that it's not um, causing them to become manic again from the antidepressant. And the idea behind it is to try and restore the balance of neurotransmitters in the brain, such as serotonin, norepinephrine, and dopamine. So here's the groups, and we'll just go through one group at a time. The first two, definitely the most common: selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors. They're very similar to each other, and they're by far the most commonly prescribed antidepressants currently. As I mentioned before, tricyclic antidepressants came before them. They can still be used, but higher toxicity in overdoses, so not as commonly prescribed. Monoamine oxidase inhibitors came before tricyclic antidepressants. Lots of side effects, lots of drug interactions, and lots of food interactions. And then lastly, there's a few atypical antidepressants that don't fit into any one of these boxes, and we can mention some of those as well. Okay, so let's go to a prototype slide here for SSRIs. And paroxetine is being used as the prototype drug. All the other ones under similar are also different types of SSRIs. So sertraline is Zoloft, citalopram, Celexa, and so on. Fluoxetine was actually the first one. That one's Prozac. And so they're all under the SSRI group. And under indications, you'll see that they're indicated for most of the anxiety disorders that we've spoken about earlier in this module, plus depression. And depression in itself, um, so unipolar depression, or the depressive phase of a bipolar illness. So how do they work? Well, it's felt that they increase serotonin in the synaptic cleft, thereby improving and elevating mood. The different SSRIs have slightly different side effects. One SSRI might be more effective than another for a particular patient. So sometimes either because of adverse effects or effectiveness, a different SSRI can be tried in the same patient. So let's look at the adverse effects, and we're gonna, there's some nausea and tremor and fatigue, but we're gonna go right to one of the most common adverse effects, and that's sexual dysfunction. So, and this can be a big problem because it can lead to decreased libido. It can cause anorgasmia, meaning inability to reach an orgasm uh, on these medications, and it can cause also impotence, so inability to have an erection. So, and these are pretty common side effects of SSRIs. So not everyone wants to continue with an SSRI because of the sexual dysfunction. You can have weight gain or weight loss on SSRIs. They can lead to a condition called serotonin syndrome, which we'll talk about on another slide, but basically it's due to the increased serotonin levels in the brain. Leads to a particular syndrome if too much of an SSRI is taken or if there's an overdose of an SSRI. Bruxism is grinding of the teeth, and that can occur with these medications. Sometimes they need to be stopped, or sometimes we'll add a sedative, such as buspirone, to settle the bruxism in a patient taking an SSRI. Another adverse effect is the ability to withdraw from these medications. You get a withdrawal syndrome once you've been on these for a period of time, which is typically months. So initially, an episode of depression was treated with an SSRI for 4 to 6 months. And now patients are staying on SSRIs for years and decades. When the SSRI is withdrawn abruptly or somebody runs out of pills, there's a withdrawal syndrome that occurs, and we'll talk about that on another slide as well. And lastly, the one I'm going to mention is, well, almost lastly. In some of these SRIs are more stimulating, so they're more activating to the body than others. So, for example, fluoxetine, which is Prozac, it's an antidepressant in this group, but it has more ability to cause anxiety and agitation, whereas others have more sedative properties and they tend not to cause anxiety and insomnia like fluoxetine can. And paroxetine would be one of those, which tends to be more of a sedating SSRI. So there are little differences. I don't think it's important to know that the tiny differences between the two, but that's why you'll see an assortment of different adverse effects. Weight gain, weight loss. So the big ones here are going to be serotonin syndrome, bruxism, withdrawal syndrome, and also knowing that there's an increase in suicidal ideation, especially in adolescents and children, which now has a black box warning for adolescents and children taking SSRIs. So contraindications. So pregnancy. It's not really a contraindication. We just don't have a lot of information in terms of some of the adverse effects and potential harm they can cause, but to the fetus. But they've been used a long time in pregnant women, and it's been deemed that it's more important to treat the depression than the potential adverse effects or potential toxicity of the SSRI. And because they've been used for years in pregnancy, they're felt to be safer uh, um, than we initially thought. So they are used in pregnancy. They have a category D, but they're not completely contraindicated. Just we're always careful with medications. So obviously this doesn't reach an A or a B level, but just so you know, they are used in pregnancy to treat depression. There's those MAOI inhibitors again. or TCAs, well, you're not usually going to combine another antidepressant with one that someone's taking. So you're going to see that quite frequently, that, okay, don't combine this with a tricyclic antidepressant or a monoamine oxidase inhibitor, uh, because they're all antidepressants, and that would create incredible levels of serotonin. So, telling the patient in terms of expectations that it can take 2, 3, 4 weeks to start having an effect. Advising them on the sexual dysfunction that frequently happens with these medications. Having a discussion about suicidal ideation being increased when initiating these drugs. And also advising them in terms of with the withdrawal syndrome that can happen if they just abruptly stop taking the drug or start to miss doses. Now, just before finishing this slide, I wanted to just make a slight correction that so paroxetine is a pregnancy D category, but other SSRIs are actually pregnancy C. And they are used in pregnancy very frequently for depression. So just wanted to make you aware that most of them are actually pregnancy C. Okay, so this slide, the prototype is fluoxetine, which again is an SSRI. It's actually one of it's the first one that was produced. And again, you can see that it can be used in anxiety conditions and depression. It's the same action as paroxetine and the others. The adverse effects are very similar. Fluoxetine happens to be a more stimulating SSRI. So someone who has a lot of anxiety and depression likely wouldn't receive fluoxetine because of its stimulating action. Okay, so there's slight variations between them, which I don't think is overly important, but you'll just see that CNS stimulation has been listed with fluoxetine. The serotonin syndrome is the same. The withdrawal syndrome can occur. Hyponatremia, so low serum sodium, is felt to be due to an effect where ADH is secreted more from the pituitary, which reabsorbs more water while taking this drug, and you get a lower serum sodium. Okay. Bruxism also occurs with any of the SSRIs. And then you'll see GI bleeding as a potential side effect. And this is because this group of drugs can interact with platelets. And because they block serotonin from getting into those little cells called platelets, and the platelets don't aggregate and adhere as well to form a clot. So that's why you'll see gastrointestinal bleed. That's a pretty minor side effect. I would concentrate more on sexual dysfunction, serotonin syndrome, withdrawal syndrome, and bruxism. Those would be more of the ones that I'd try to concentrate on. So it's a pregnancy category C, as are the other SSRIs except for paroxetine. Avoid with other antidepressants such as MAOI inhibitors. Those are those very, very old antidepressants, or tricyclic antidepressants, which are moderately old. So nursing considerations, SSRIs are definitely first-line drugs, first-line treatment for depression. Often takes 1, 2, 3, 4 weeks to start to be effective. And just remember the adverse effects that we've discussed with them. Okay, so venlafaxine, the brand name is Effexor. Very similar, but it's a selective norepinephrine reuptake inhibitor. Uh, it, it still inhibits serotonin reuptake as well, so it has dual effect of increasing norepinephrine and increasing serotonin. Okay, and it's used for depressive illnesses and an assortment of anxiety conditions. And you'll also see it as a pain modulator. So sometimes drugs find other indications, um, and SSRIs, or in this case SNRIs, are used for chronic low back pain when you don't want to have a patient continue on opioid drugs for years and years and years. And sometimes an antidepressant such as venlafaxine can be tried for chronic back pain because it's felt it can have an underlying depressive illness or a emotional aspect to it. So it's definitely attempted for chronic low back pain. It's also tried for diabetic neuropathy sometimes, so numbness in the legs in diabetics. This is one group of drugs that can be attempted to see if it can improve the symptoms of diabetic neuropathy. Not a common indication. The main one is depression and anxiety disorders. Okay, adverse effects. The first one is definitely the biggest. It can lead to hypertension, which kind of makes sense. It's increasing norepinephrine in the bloodstream, and that is that causes vasoconstriction of the blood vessels, leading to hypertension. So patients' blood pressures are monitored if they're on venlafaxine. The other adverse effects are not quite as important as the hypertension, but again, you'll see that withdrawal syndrome can occur with venlafaxine, just like the SSRIs. The suicidal ideation in children and adolescents is an issue, so it would also have a black box warning. The sexual dysfunction can still occur, but not to the same extent as some of the SSRIs. And lastly, because it also increases serotonin, you can get this condition that we'll discuss called serotonin syndrome. So a lot of these adverse effects can just be somewhat predicted by the effect of increasing norepinephrine, right? The insomnia, because norepinephrine is a stimulating catecholamine in the bloodstream. So insomnia, anxiety can it can cause anxiety, tachycardia, dizziness. So those are predictable, and the hypertension they're predictable based on increasing the norepinephrine. Contraindications, definitely not combining these with an SSRI. That's going to create incredible amounts of serotonin in the bloodstream. And definitely, again, not using MAOI inhibitors or TCAs in combination with this group. We rarely do we use two antidepressants in one patient. So discontinuing this medication 2 weeks if someone has resistant depression and the plan is for them to go on to an MAOI inhibitor. So you can see they really want to keep these drugs apart because of the potential for bad interactions and serotonin syndrome. They are used in older patients for sure because older patients are one category where there's an increased risk of depression, right? There's more social isolation. Often they live by themselves, so they have a high incidence of depression. Patients with bipolar disease, they're still used, but remember, it can make someone manic. They can go from depression to mania quickly. This can cause seizures in someone who has a seizure disorder. So we're just careful not increasing the dose quickly, or going to very high doses um, with venlafaxine. And because of the potential to increase hypertension, we would be careful with someone who's had a recent heart attack because it can increase blood pressure and it can also cause tachycardia. And here's serotonin syndrome. So it's due to increased serotonin levels in the brain, and it's usually from drugs. So the SSRIs, the SNRIs are very commonly associated with serotonin syndrome, especially if they're at high doses or if somebody takes an intentional or unintentional overdose. So you can see that there's a lot of uh, agitation type symptoms. So restlessness, tremor, rigidity of muscles. They're hyperreflexic. They're really twitchy and anxious. They have elevation of temperatures because their thermal regulation has now been altered. They often have a fast heart rate. They're tachycardic. And if it if the serotonin reaches very high levels because of an overdose, it can be fatal due to cardiac arrhythmias. So typically, it's from having taken an overdose of one SSRI, or if it's or it can be due to um, combined treatments of different medications in different groups. So an SSRI with a tricyclic. So that's why we typically don't combine them. So definitely the most common cause is just a very high dose of one particular drug or an overdose. The treatment is usually just stopping the medication, and because they can have high fevers or high temperatures, we can use cooling blankets. And also because they're so agitated, we'll use benzodiazepines to settle down the agitation. Now, there is a medication that we sometimes use that's not overly effective for serotonin syndrome. It's called cyproheptadine. If you don't see it in your readings, fine. If you happen to see cyproheptadine as a treatment for serotonin syndrome, well, there you go. It's been mentioned. So I wouldn't spend too much time looking into that. And the prevention is avoiding high doses of, of an SSRI or being very careful when you're switching from one antidepressant to another and making sure that there's a washout time of where one antidepressant can clear the system before starting the next one. This next slide is showing you the symptoms that patients will get once they've been on an SSRI or an SNRI for depression or anxiety, and then they withdraw the medication abruptly. And of course, we advise patients not to discontinue these medications abruptly because they will get some of these symptoms. So they can get flu-like symptoms, they can get insomnia, they can have nausea, but a big one is these this imbalance. So people get very odd symptoms with their eyes, where they don't seem to be able to track normally. They feel a bit lightheaded. They can be off balance. All kinds of visual disturbances, as I mentioned, and electric shocks in their body have been reported, and then hyperarousal, so increased agitation and anxiety. So it's not a good feeling to withdraw from SSRIs or SNRIs. And patients notice it even when they miss a few days of doses. of these medications once they've been on for a day or two. So typically, uh, these drugs will be titrated down. They'll be reduced over the span of days to weeks to limit uh, the uh, the discontinuation syndrome. And usually this occurs 1, 2, or 3 days following uh, stopping the medication, and it can last for a couple of weeks. So people usually return with these symptoms and want to restart the SSRI or SNRI and then taper off it slowly. Okay, so amitriptyline. So this is a tricyclic antidepressant. This is an older antidepressant. This is what we used before we had SSRIs and SNRIs, which is over 20 years now. And it's still around. Tricyclic antidepressants are still around. You can see how many there are um, that are available because these were the #1 antidepressants prior to SSRIs. And what are they used for now? Well, they can still be used for depression. I think I mentioned that some of them are very fatiguing, such as amitriptyline. They can they can make you tired, so they're used for insomnia, a low dose at bedtime to help sleep. And like venlafaxine, which is an SNRI, you see that these tricyclic antidepressants are used for chronic pain syndromes, fibromyalgia. They're tried for diabetic neuropathy because we think that some of these conditions have an emotional component or a depressive component to them, and they can be helped by taking a tricyclic antidepressant. Okay, so I would say the most common reason for seeing someone on a low dose of amitriptyline is for sleeping, or fibromyalgia, or diabetic neuropathy, the numbness and pain they get in their legs. Okay, the action very similar to SSRIs, increases norepinephrine and serotonin. Remember, one of the main reasons we switched away from these drugs was because of their potential for toxicity. In overdose, it could definitely kill someone more easily than an SSRI or an SNRI. So adverse effects, they have a lot of anticholinergic side effects. So what's anticholinergic? So blocking the parasympathetic system. So what do they get? Well, they can get blurry vision because their eyes dilate. They can get really dry mouth because the secretions are reduced in their mouth. They can get constipation because the cholinergic system is responsible for stimulating the gut. So anticholinergic symptoms, and the main one when we're talking about these drugs is really a dry mouth. Blurry vision would be another one. Sometimes they can get orthostatic hypotension, meaning if they stand up too quickly, they get dizzy because the blood pressure isn't maintained. And again, that's due to their anticholinergic effects. They're very sedating, and that's why we use them. We use some of these for sleeping. Not great in old patients though, because of their sedative qualities. They can definitely lead to seizures in a patient with a seizure condition, epilepsy, or a seizure condition. It decreases the threshold of getting a seizure. So these are just some of the adverse effects of TCAs. Okay, so contraindications. Well, they were used for years in pregnancy, so they're a pregnancy C. Difficult to treat seizure disorders would be a contraindication. Urinary or bowel obstruction or retention. Okay, well, these are anticholinergics. They slow down the bowel and they inhibit bladder contractions because they're blocking the parasympathetic system. So if someone has a bowel obstruction, or if they get very constipated, or an older man has problems urinating due to a large prostate, this could tip them over the edge of not being able to have a bowel movement or tip them into urinary retention. Okay. Glaucoma can be a contraindication because only one type of glaucoma, which is open angle glaucoma, and we won't get into that. But when the eye dilates, it can lead to an acute episode of a closed angle glaucoma. Sorry, if I mentioned open angle glaucoma, I was mistaken. So, and let me repeat that. So, due to their anticholinergic effects, they cause dilation of the pupils, and that can trigger an acute closed angle glaucoma episode, which can be eye threatening. Okay. Benign prostatic hypertrophy is just what we spoke about. It can cause urinary retention because it's reducing the contractions of the bladder muscle due to its anticholinergic effects. Okay, so those are just some of the contraindications and some of the reasons why we don't use them as much anymore. So tricyclic antidepressants, again, can take weeks to work. They're not instantaneous at all, except maybe for sleeping because they're so sedating. But in terms of their antidepressant effects, it's typically weeks, and often we'll say 3, 4, 5 weeks before you can expect an effect. So what can you recommend to someone who's on a tricyclic antidepressant to try and help some of their symptoms? So, their adverse effects. So chewing gum can help, right? Because they often have a dry mouth. Taking sips of water throughout the day can be very helpful. Avoiding constipation by increasing fluid intake and increasing their fiber intake and making sure they get regular exercise, which, by the way, improves depression, but also it avoids the constipation that can happen with these drugs. And lastly, um, just want you to remember that this is really a secondary group now for depressive illnesses. Uh, Again, because of the toxicity when they're taken in overdose. And the toxicity is significant. They can get severe cardiac arrhythmias. They often end up in intensive care units. And because of that, a big switch occurred when the SSRIs came out decades ago. Okay, so let's talk a bit about MAOI inhibitors. The prototype here would be phenelzine. There's one that comes as a transdermal patch, selegiline, and there's a few others. But I think if you recognize the group MAOI inhibitors, because they really are older generation antidepressants. So, and that would be the main indication for them, severe resistant depression. There's other uses. They can be tried in severe anxiety once other medications have been attempted. They are sometimes used in bulimia to see if it can improve the symptoms and behavior of bulimia. And they have an effect on the brain by also increasing norepinephrine, dopamine, and serotonin, plus tyramine in in the uh, in the system. Okay, so and that's gonna come into play with some of the food issues that occur with taking these medications. So, what are the adverse effects of MAOI inhibitors? So firstly, they can lead to overstimulation of the brain by just releasing too much of those neurotransmitters, so CNS stimulation. They can also lead to some orthostatic hypotension symptoms. So when someone gets up too quickly, they feel dizzy, off balance, and they can actually fall because the blood pressure wasn't maintained when they stood up quickly. The big one is hypertensive crisis. That can occur if these are combined with other antidepressants, which often they aren't, but even more importantly, the diet restrictions that patients have to adhere to if they're on these medications, and that's really important. They can also lead to serotonin syndrome, again, at high doses of the drug, or an overdose of the drug can lead to serotonin syndrome. So let's just see if we can explain some of these contraindications. So they're pregnancy category C, and again, we don't use these drugs very often anymore. But if for severe depression we do use them, they're pregnancy category C. Contraindicated in someone with a pheochromocytoma. That's a rare adrenal tumor, so an adrenal gland tumor that is secreting large amounts of epinephrine or norepinephrine. So you can imagine if you have this tumor on your adrenal gland, plus you're taking a drug that's releasing norepinephrine, it's going to cause a hypertensive crisis. Pheochromocytomas are extremely rare, so I just wanted to explain it to you. Heart failure, cardiovascular disease, well, that's because of the potential for hypertension with these drugs, right? So, because in settings where someone's either, well, first of all, these secrete or increase levels of norepinephrine. So that can cause more hypertension. That can lead to stimulation of the heart because it's a catecholamine, it's a stimulant, norepinephrine or epinephrine, and that can aggravate someone's heart failure. So these contraindications are relative contraindications. Can you still take the drug with these conditions? Yes, but there would be a lot of care and observation and follow-ups if you had these conditions. Okay, so let's talk about avoiding foods that contain tyramine. That is crucial. And the reason it's crucial is tyramine, when eaten, can increase the levels of tyramine because this drug or these drugs, the MAO inhibitors, also increase tyramine. And it can lead to a hypertensive crisis. So that's the big concern with eating food that contain tyramine, leading to a hypertensive crisis while on this drug. That can lead to a CVA, cerebral vascular accident, which is also called a stroke. Okay, so severe hypertension is a concern. So they need to be advised very carefully on what foods they need to avoid. So let's look at some of the foods that contain tyramine. And I just want to explain this action a bit more so it makes sense. So MAOI inhibitors are responsible for blocking an enzyme that break down tyramine. So because that enzyme is blocked, when you eat tyramine, it can increase to very high levels in the bloodstream that can then lead to severe hypertension. And patients have died from this, from the severe hypertension that the MAOI inhibitors can cause. Okay, so what type of foods are rich in tyramine that they can no longer eat while on these medications? And it's usually aged food, so aged cheeses, aged meats like pepperoni or salami, anything that's had time to ripen. So ripened bananas, ripened figs, avocados, anything that's been smoked, like fish. There's some beers that have tyramine and also some wines that have tyramine. So think of smoked foods like aged cheeses and aged wines and aged meats. Okay. So you can see that patients need to adhere to a really strict diet of avoiding these foods. And they're often given sheets of foods that they cannot eat under any circumstances. And it's explained to them the risk of eating those foods while taking an MAOI inhibitor. Okay, so let's just look at some other interactions. So think of MAOI inhibitors as increasing all these neurotransmitters in the brain, and anything else that's a stimulant should not be taken with them. So medications like decongestants that you might buy for your stuffy nose should not be used with MAOI inhibitors. So many cold remedies, over-the-counter remedies, that's a bad idea because they often have decongestants in them. Definitely any use of other antidepressants like tricyclic antidepressants or SSRIs, totally avoided. And lastly, there is an old opioid. It's still around. We don't use it very much, called meperidine. The brand name is Demerol, and that has a very severe interaction with MAOI inhibitors, leading to uncontrolled fevers. Fevers to the point where there's brain damage and death. So there's a case that occurred many, many years ago in New York State where two interns were working, and it was at a time when you had to work 48, 72 hours in a row. A young lady came in that was on an MAOI inhibitor and was given meperidine for her pain. She went into she developed extremely high temperatures of 104, 105, and had seizures and finally died. And that case actually changed a lot of regulations in terms of how long someone can work in a hospital. So significant interaction there. So just remember any stimulants, and you'll see that uh, patients will often be advised not even to take herbal remedies in case that they have some stimulating effects, such as avoiding caffeinated beverages, chocolates. So there's many dietary restrictions, and it's a good idea to have an idea of those tyramine-rich foods. Okay, next we're going to talk about a drug called bupropion. And depending what it's being used for, it's either a brand name called Wellbutrin or Zyban, because the two reasons for taking this medication can be as an antidepressant, brand name Wellbutrin, or as a medication to try and stop smoking, brand name being Zyban, both identical drugs. So the reasoning for that is patients that were taking this for their depression years ago, it was noticed that they had less of a desire to smoke. So that was studied, and it was discovered that it really takes away the desire and the interest to smoke. So it was marketed as uh, a smoking cessation medication as well. Okay, so bupropion, we mentioned smoking cessation, and for depression, and different seasonal affective depression is also included in using bupropion. And sometimes it's used in attention deficit disorder. But mainly, I would view it as a medication to either stop smoking or an antidepressant. Okay. And what does it do? Well, very similar to other ones. Inhibits norepinephrine and dopamine reuptake. So there's increased levels of norepinephrine and dopamine. The adverse effects, the main ones will be restlessness, insomnia, lack of appetite. So it's a bit of an agitating drug. It can create some anxiety. So someone who has a lot of anxiety with their depression would likely not be a very good candidate for this drug. Okay, so you might be able to remember it that way, that it causes, and that's the reason why some patients can't take it for depression, because it increases their anxiety. And under adverse effects, you'll see that with tachycardia, hypertension, restlessness, insomnia. Those are all anxiety symptoms that are coming out. Contraindications, of course, MAOI inhibitors. They can worsen seizures, so patients with seizure disorders. It's quite safe in pregnancy, so can be used in pregnancy. And I think that's all we need to say about this one. It's an atypical antidepressant only because it doesn't fit into one of our specific classes, such as SSRI, SNRI, MAOI inhibitors, and TCAs. Okay, so we're going to move on to a different topic, anesthetics. So we're moving away from depression and anxiety. I know not all the drugs that were in your your hand your book were mentioned. There were other atypical antidepressants, for example, that I didn't go into. And again, they have similar actions, similar ways of increasing the neurotransmitters at the synaptic cleft. So whether it's mirtazapine or trazodone, very similar effects. So I think they're mentioned there, but not a lot of information on each. I think we've covered the main ones, the SSRIs, the SNRIs, the TCAs, and the old MAOI inhibitors. So hopefully that helps you just read the the book with more ease. Okay, so let's move on to some other medications, and we'll start with some information on anesthesia. Okay, so when we're talking about anesthesia, what is it? Well, it's a loss of sensation and awareness during an intervention, right? So during a surgical intervention. So it often consists of an analgesic, and that's usually an opioid analgesic. And the main one that we use intravenously is fentanyl. I know we're not doing it right now, but I just mentioned it to you. It's an opioid analgesic. A medication for amnesia, so that's typically a strong sedative, and that could be something like a gas anesthetic, or we could use an intravenous anesthetic or drug that's very sedating, such as propofol, or we could actually use a high dose of a benzodiazepine to put you to sleep, and also a neuromuscular blocker. So why do we use a neuromuscular blocker? Well, it paralyzes you. It blocks all the muscles in your body from functioning or moving so that a surgical procedure can be done, right? So The analgesic is for the pain. The amnestic is for um, having no memory of the event, which is usually good. And the neuromuscular blocker is so that you don't move. So for example, during intubation, which is putting a breathing tube uh, into someone's trachea, we need an analgesic because it's a painful procedure, and IV fentanyl is often used. We need an amnestic drug, so a drug that's going to sedate the patient to the point of not remembering the event. And that could easily be propofol or a very high dose of a benzodiazepine, but propofol is often used for that. And we use a neuromuscular junction so that their neck is completely relaxed and we can easily open up their throat to put the tube in. So often these are combined. So medications as an anesthetic can be inhaled, so gas anesthetics, or they can be given IV, such as propofol, which is a powerful sedative that it renders the patient unconscious. So what are the types of anesthetics? So there's local, which we just want to numb a small area of your body, say for example to put in stitches or to remove a lesion that's on your skin. We can use a local anesthetic such as lidocaine. There's regional blocks where we can numb up a whole arm or a whole leg, and another example is an epidural anesthetic, where a needle goes in, a spinal needle goes in and numbs the tissue from typically the pelvis down both legs uh, for uh, for childbirth, but it can also be used for surgery on the leg, um, or lower abdominal surgery that it's too high of a risk to give the person a general anesthetic. Okay, so that's regional. And then general is that the patient is fully unconscious. And that's often either with inhaled anesthetics, such as halothane, or IV drugs, such as propofol or ketamine. They render you unconscious. Plus the paralytic that I mentioned, uh, to stop them from moving completely. And that's something like succinylcholine or rocuronium. Now, we're not going to talk about all these drugs, so don't think you need to memorize all these drugs. I'm just giving you the sequence, and I'm mentioning a couple of drugs. You will see them later on in pharmacology, whether it's this semester or next semester. So just giving you an idea of what different types of anesthetics, local, regional, and general. Okay, and this slide again, showing you the differences between local anesthetic. You're definitely awake. They come in creams or gels that we can put directly on the skin, or often it's a local injection into the tissue to numb up the skin, and whether it's for dental procedures or emergency room procedures. And then we go to regional anesthetics that we spoke about, and then finally general anesthetics where you're completely unconscious, and often it's a combination of a gas anesthetic and an intravenous drugs. Okay. And here's a slide on general anesthesia, complete loss of consciousness uh, with complete loss of sensation. So you have no awareness. And that's definitely for major surgeries, right? So operating room. And the purposes of the different drugs, well, we mentioned intravenous fentanyl, which is a powerful opioid. Relaxation is obtained with a benzodiazepine or propofol, which is a powerful sedative. Hypnosis, which is sleeping. can be obtained with either one of those, like again, propofol or benzodiazepine. And then the amnestic component, the lack of memory, is really the use with occurs with inhaled gases such as halothane or intravenous propofol. And really, you have no protection of your airway, so typically you need some kind of airway support, such as intubation, or sometimes other devices are used that are put into the throat uh, to to continue with airway and breathing for the patient. So balanced anesthesia is just balancing all these drugs to obtain the anesthesia that is required for the procedure. And here we have some prototype drugs for anesthesia. Again, fentanyl will pop up a lot because it's a very popular intravenous opioid. Um, it's very powerful. It obtains pain control very quickly. Midazolam is a benzodiazepine that we use intravenously for sedation in the operating room or in the emergency room. Propofol, a very powerful sedative that can easily put someone completely asleep within minutes of administering it. Nitric oxide is a gas. It's often used just for sedation, say for a dental procedure, or where you just want to settle someone down in the emergency room or in a dental office. Isoflurane is a gas anesthetic. It'll induce complete amnesia and unconsciousness. Procaine and lidocaine are injectable anesthetics. So we can freeze part of the skin. We can freeze a digit. We can do a nerve block in your mouth for a dental procedure. So those are local, typically local anesthetics. And then barbiturates, definitely less used now because of all their adverse effects, but they're powerful IV sedatives. Okay, so here's a bit of a repetition from a previous slide, but never hurts to just to hear it twice, or maybe get a different, sometimes just a different idea about them. So local anesthetic, remember, you don't lose consciousness with a local anesthetic, right? So whether you're freezing part of your mouth or a ring block that we use to freeze a digit, such as a finger or a toe, or we can put a whole bunch of freezing around a laceration to stitch it back together. The regional block, so there's one called a beer block, where we put a blood pressure cuff uh, on your upper leg or upper arm, and we pump it to high levels, and that blocks the flow of blood from leaving, and then we inject uh, anesthetic so that the whole arm is completely numb, or the whole leg, and then any procedure can be done on that part of the body, and you're still awake. Okay, so local and regional anesthetics have definitely less adverse effects. You're wide awake, so they tend to be safer than a general anesthetic. So when we're doing a procedure on someone and we're putting them to sleep with powerful sedatives, so intravenous sedatives and intravenous painkillers, and they're typically opioids, they need monitoring, right? So they typically need a cardiac monitor that you can see in this picture. They need a suction. We need a suction machine in case they vomit and aspirate. So that's important to have nearby and on. We need a source of oxygen because they can run into problems with their airway and breathing. They can become hypoxic, low on oxygen. because some of these drugs slow down breathing, such as benzodiazepines and opioids. We need a resuscitation bag, so a bag valve mask that you can see in the top right-hand corner there. And sometimes we have to bag patients where we've given them just too much drugs for their body, and they stop breathing. And we just need to bag them for a period of time until the drug starts to wear off. A pulse oximeter to monitor their oxygen levels in their blood to make sure that they're getting enough oxygen. And if they're not, we'll give them supplemental oxygen. And we need a very good light source for whatever we're doing, right? I mean, that doesn't show this light source in this picture is just a bit of a joke, but we need a good light source so that we see exactly what we're doing. So all of these pieces of equipment are really important. The towel for positioning is sometimes we have to put a towel behind someone's shoulders when we're intubating them, so we get the proper angle from their mouth directly down to their trachea. So certain people, we have to adjust where their neck is and their head are lying so we get a good position. Okay, so let's just talk briefly about opioids. And intravenous opioids, I've mentioned fentanyl, which is a very common one, but intravenous morphine can be used. The advantage of fentanyl is it doesn't last very long, so if there's a significant side effect, it tends to wear off faster than, say, morphine. Okay, but they can both be used intravenously. It has a very rapid onset, so it can be used uh, to quickly obtain pain control in the emergency room. For example, someone who's had a traumatic hand injury from a chainsaw, or they've lost digits, or any painful procedure, we can use intravenous fentanyl to get good pain control. So, like any opioid or narcotic, respiratory depression and hypotension are the big ones to remember. Okay, these can lead to apnea and they can lead to hypotensive. So they always need monitoring when they're receiving intravenous narcotics. And we need a lot of the equipment that you saw on the previous slide, right? We need to have the airway equipment nearby. If we're giving IV sedation, such as a benzodiazepine, IV analgesia, such as fentanyl, or definitely any kind of a paralytic drug that stops a patient from breathing on top of paralyzing them. We always have to have airway equipment nearby in case they stop breathing or they need supplemental airway support. Okay, and that's usually a bag valve mask to bag them manually, suction in case they vomit. An oral airway is a little plastic airway that we can put into someone's mouth to get past the tongue so that the tongue doesn't collapse and they can't get air in. An oxygen supply, and even possibly just having naloxone, which reverses a narcotic or IV narcotic use. So it'll reverse that. And so often we'll have flumazenil around that will reverse too much benzodiazepine use. Okay, well, I guess I don't need to spend too much time on this slide, fentanyl, since I've spoken about it a lot. So it's an opioid agonist. So it's an intravenous opioid drug. So is morphine and a number of other ones. The similar ones listed there aren't used as much as fentanyl for sure. And why do we use it? What's the action? Well, it acts on the opioid receptors to control painful stimulus, right? Main adverse effects: respiratory depression and cardiac depression and hypotension. So we keep an eye on their respiratory rate, their oxygen saturation, and their heart rate and blood pressure. Definitely sedating. When you give this intravenous, you can tell the patient's becoming quite sedated on the opioid. If used for a long time, any narcotic can be constipating. So that's kind of the hallmark of any narcotic. So patients that go home on oral narcotics or opioids, very constipating. Okay, so fentanyl can also do that. And also opioids as a group, including fentanyl, can cause confusion. Contraindications, well, an opioid allergy to that particular opioid. And definitely we would have to avoid these in someone who was hypotensive or was not breathing properly, some kind of respiratory compromise, because it would worsen it. So so always being aware that it's ABCs, checking their airway, monitoring their airway and vital signs when giving intravenous narcotics or opioids. Having a cardiac monitor around, an ECG monitor, and having all the resuscitation equipment in case they stop breathing or they go hypertensive and need intravenous fluids. Okay, and this is a Schedule II drug, so these intravenous opioids definitely need close monitoring. Okay, so the next prototype drug is called propofol. And propofol comes as a milky liquid. So, we nickname it milk of amnesia, since it has very powerful amnestic properties, and I'll talk about that. So it's a very, very powerful sedative. So we use it for deep sedation, whether it's in the emergency room or someone who's intubated, or to intubate someone. We can use propofol. Or say we just need to put someone's shoulder back in place from a dislocation. We can use propofol intravenously to completely sedate them while we're relocating their shoulder. So very effective deep sedative. What does it do? Well, complete loss of consciousness if a high enough dose, but we typically get to that dose when we need it for intubation or mechanical ventilation. What are the adverse effects? Well, it's soya based. It's very milky, so you can't leave this medication out in its liquid form. Otherwise, it can start to get infected with bacteria. You can get what's called a propofol infusion syndrome, and we'll talk about that on the next slide. Hypotension is a big factor with this drug. It relaxes patients so much that they become hypotensive. And the other one, apnea. They stop breathing with propofol. Okay, so it's such a deep sedative that it leads to apnea. So those two should remind you of benzodiazepines a bit. They cause hypotension and they cause respiratory depression, just like propofol. And it's only an IV drug. It can cause definitely some phlebitis during the infusion. So remember, the contraindications would be if you already have hypotension or respiratory compromise. So typically if you're receiving propofol, you're on a cardiac monitor, you have an oxygen saturation on, we have all our equipment out in case we have to ventilate you. So we have a bag valve mask out, we'll have suction out to make sure that if you aspirate or if you vomit, we can suction you. We're always checking for apnea or hypotension if you're receiving this medication. And this is purely just a sedative. It has no pain or analgesic effects at all. So just by itself, it puts someone into a deep sedation. So propofol infusion syndrome is really a syndrome of high dose propofol for prolonged periods of time. So somebody in an ICU that is potentially getting very high doses of propofol to keep them sedated, unconscious, uh, could develop this syndrome. And there's many metabolic abnormalities and specific organs are affected by this drug at high doses, and we call it propofol infusion syndrome. So patients get a acidosis, so their pH is below 7.35. Their potassium can climb in the blood, so hyperkalemia. Lipidemia or lipemia, lipidemia sounds better, is because this is a fatty, kind of a fatty, lipidy substance. Um, you can develop lipidemia in the bloodstream. Muscle breakdown, rhabdomyolysis, okay, enlarged liver, and also cardiac and renal failure. So this is a recognized syndrome. Most patients would not be maintained on high doses of propofol, partly for this reason. Okay, so pentobarbital, it's a type of barbiturate, and again, it's a sedative. So propofol was a sedative, pentobarbital is a sedative, just in a different group, barbiturates. And they're not used as much anymore. They had high potential for abuse. They can still be used for sedation or someone who needs sedation for intubation, and also seizures that are not stopping with our typical approach of using benzodiazepines along with some other medications. We can turn to pentobarbital or barbiturates in general to try and stop the seizure because they have very powerful CNS depressant effects. So under adverse effects, you'll see that they'll have respiratory and cardiac depression. Okay, they're just powerful sedatives. And if someone's receiving a barbiturate, such as pentobarbital, they will have to be on a cardiac monitor, very frequent vital signs. They'll need an ECG monitoring and all the equipment around for possible an airway issue because they can become apneic and go into respiratory depression. So we went through that slide in terms of all the equipment we like to have around us when using these medications. So ketamine is a very popular drug medication. It has incredible properties for sedating someone, for having them have no memory of the event, and analgesia. So it does all of them. It sedates, it eliminates a memory of the event, and provides fantastic pain control. So really, this is only a hospital-based medication. Yes, it can be abused, but you don't go home with this medication. So as a street drug, it can be abused. In the hospital, it's hospital-based since we typically give it intravenously or we can give it intramuscularly. And because it addresses all three issues of sedation, amnesia, and analgesia, we often use it by itself for a procedure. So say a child comes in with a very deformed leg that needs to be um, relocated in terms of, straightened out because it's so displaced. We can give the child ketamine, and they will have no memory, no sensation of the event at all. The adverse effects are that some people can have really bad trips on ketamine. They can hallucinate. They can be very, very agitated upon awakening. Uh, that's the minority, but when it happens, it really is quite disturbing to see. Uh, Screaming, hallucinating, shouting out, and often we'll give those patients a benzodiazepine to calm them down after having had the ketamine. Okay, so still a very fantastic drug when you have to do painful things to patients and procedures. So we avoid this drug uh, in patients who have a history of mental illness, since they're more prone to having hallucinations and awakening with acute agitation, and patients that have substance abuse, because they're more prone to those adverse effects as well. It's very frequently used in children. We usually quieten down the lights because as you go in, when we give the ketamine, we tell patients if you can relax while you receive the ketamine, you usually have well, for lack of a better word, a good trip. Uh, and that is often the case. So typically this will give us 20 minutes to do any particular procedure that we need to do. And as I mentioned, we use a benzodiazepine sometimes, such as midazolam, uh, if they wake up and they're very agitated. The one other side effect or adverse effect, this is more of a side effect, is that it can increase secretions in the mouth. So you can imagine when they're sleeping um, while on ketamine, increased secretions we prefer not to have. So if they've had a cold or they've been coughing, we avoid ketamine since it'll increase the secretions, not only in the mouth, but in the lungs. So if we hear that they've had a cold in the past couple of weeks, we'll just avoid it. Okay, so adjuncts to anesthesia. So an adjunct are just other treatments to help in the primary treatment, which is anesthesia. So adjuncts are usually meant to make a procedure safer. So what kind of adjuncts are we talking about? Well, sometimes we'll use some preoperative medications to make the procedure more pleasant for the patient, such as midazolam or diazepam. Reducing gastric fluid volume if you're going to be intubated, or if you are going to have a procedure that is or a surgical procedure on your abdomen, a nasogastric tube to eliminate the fluid and acidity in the stomach. So that can be an adjunct to anesthesia. Preoperatively, we can dry out the mouth with atropine or another drug called glycopyrrolate. These are anticholinergic drugs. So if someone's having oral surgery, they will often receive a dose of atropine and glycopyrrolate to really dry out the whole area, which makes the surgery easier. And of course, reduction in pain preoperatively, and IV fentanyl would be the most common one used in that scenario. Okay, so we're going to change gears here, go away from general anesthetics and just talk a bit about local anesthetics. And local anesthetics are typically to choose one area of the body and anesthetize it. And they can be topically applied, such as creams, used much more in children. Say we want to do a blood test, uh, we can put a topical anesthetic on the skin to numb the skin prior to the needle stick. So topical creams are quite popular in children. We can also uh, freeze areas of the body or anesthetize areas of the body prior to a procedure, such as repairing a laceration or removing a lesion that's on the body. And that's done by injecting an area of skin, or say freezing an entire finger, or in some cases freezing an entire arm or leg. And we'll get to that. And that's that's accomplished by either injecting the tissue and anesthetizing all the tissue in the area where you want to work. Or another option is actually to numb the nerves or anesthetize the nerves that go to that area. So we'll look at that a bit. Okay, so we spoke about anesthetizing an area of skin, uh, say with a local anesthetic such as lidocaine. We can also anesthetize a larger area, so a regional block. Uh, so we can choose a particular nerve, and this would apply to, say, a dental procedure where they anesthetize a nerve that's supplying the area so that the whole area is anesthetized so that they can do their dental procedure. We can do that with nerve blocks, say, to the hip. So someone comes in with a hip fracture. Instead of having to give them intravenous morphine for many hours, you can actually inject anesthetic around where the nerve is supplying the hip, and they can have a complete lack of sensation of the hip fracture until they can get to surgery. So nerve blocks can be very effective. Another example would be freezing an entire finger. So we can go after the nerves that supply the digit, freeze the nerves so that the entire digit is now anesthetized, and we can work on whatever needs doing to that particular finger. Okay. Epidural anesthesia is injecting anesthetic into the epidural space. It blocks all the nerve roots, or it anesthetizes all the nerve roots, typically from the abdomen, pelvis, and the limbs. So definitely used for OB during labor, but also other surgeries lower down. So urologic procedures where you don't want to put the patient to sleep necessarily. So epidural anesthesia can be a very effective form of anesthesia. So spinal anesthesia, very similar. So in the lumbar area, the anesthetic is injected into the CSF, and it blocks, again, a large area of the lower abdomen, pelvis, and legs. So you can have a surgical procedure on your leg, still be awake, hopefully with a bit of sedation, because there's probably some noise going on in the room. Um, uh, but you don't have to undergo a general anesthetic. And some patients aren't well enough. They either have heart disease or lung disease, where they just can't undergo a general anesthetic, and a spinal anesthetic will be used instead. Okay, so we'll just go through these quickly. So lidocaine is a local anesthetic that's injected, whether it's a nerve block or right directly into the tissue to anesthetize the tissue. It's in the group called amides as a local anesthetic. Tends to have very low allergic reactions, works very quickly within minutes, and on average it'll last about an hour and a half. Just depends on how much blood flow is in the area that can wash the lidocaine away, but in general about an hour and a half. So, as I mentioned, a local anesthetic, say if you have a laceration on your arm, we can freeze the whole area, anesthetize, sorry, with lidocaine so that you don't feel the procedure. It can also be used in regional or epidural blocks. The patches wouldn't be used very often. They can help with the pain of post-herpetic neuralgia, but the patches are less frequently used. Topical, as I mentioned, is used frequently in children so that they don't feel a minor procedure such as a blood test or maybe even just a small laceration. We can put some topical lidocaine on to numb the area. And sometimes we'll use topical lidocaine in the mouth to numb, say, an oral ulcer, so that patients can eat. So we'll probably talk about that in another module where topical lidocaine is used for pain control for oral ulcers. Okay, so another example of an anesthetic, tetracaine, a local anesthetic, can be used as creams as well for the skin, eye drops to numb the eye, so we can do procedures. Say you have a foreign body on your eyeball that we need to remove. Well, you won't let us touch it until we can anesthetize the eye. So we can put tetracaine eye drops in. Intravenously, we'll talk about when we're talking about a regional block that can be done with tetracaine. This is an ester type local anesthetic. It has more potential for allergies than lidocaine. Okay. This is typically also used more so than lidocaine in spinal anesthesia and epidurals. So it can also be used in the nose and throat, sprayed into the nose and throat for painful conditions that need to be done there. It can be used on the skin when you have a painful skin condition. I'm sure if you go to the pharmacy, you'll see probably Solarcaine or different anesthetic sprays for sunburns or painful skin conditions, such as cold sores and oral ulcers. Again, it can be used. So works very rapidly, and it's very similar to lidocaine, just a bit more potential for allergic reactions with because it's ester based, which is just describing the molecule. Okay, so why are we talking about systemic toxicity of local anesthetics? Well, if you give enough of whether it's lidocaine or tetracaine into the tissue or as a epidural or as a spinal anesthetic, you can put enough in that it will get into the bloodstream. And this is partly why when we're injecting lidocaine, we pull back on the syringe to make sure that we're not in a blood vessel and we directly inject the lidocaine into a blood vessel that gets into the circulation. So it takes quite a bit of lidocaine to cause toxicity, but it can certainly happen. So here are the symptoms of lidocaine toxicity when given in high enough doses that it's made it into the systemic circulation. So paresthesias, so numbness, whether it's to the body or to the lips and tongue. Well, that's what lidocaine does anywhere. It numbs areas. So it's starting to do that to the entire body. Altered central nervous system, So dizziness, restlessness, confusion can start to take place as the lidocaine is having a direct effect on the brain. And then finally, muscle twitching, and the most serious is seizures. And that's what we're most concerned about, that the intravenous lidocaine or tetracaine has led to seizure activity, because they can be extremely difficult to treat. So remember, we're talking about unintentionally giving too high of a dose, whether it's to a child with a very large laceration and we've taken lots of injectable lidocaine to freeze the whole area, and then forgetting that it could have systemic toxicity. So we always need to keep in mind the maximum dose we can give based on weight, for a child or an adult, to prevent this scenario. Okay, so seizures, and lastly, it can cause respiratory depression, and then respiratory arrest and cardiac arrest. So that's just a bit on lidocaine toxicity, or tetracaine. Okay, so we're going to go through some anti-epileptic medications pretty fast. I'm over my module limit because I don't want to give you too many hours per week. So we're going to talk briefly about epilepsy and then just go through some anti-seizure or anti-epileptic medications. Not in very, very high detail, but just to give you some ideas about them and some common adverse effects. Okay, so seizure disorders. So if they're recurrent, we call it epilepsy. So if you have one seizure from say, alcohol withdrawal, well, that's an alcohol withdrawal seizure. We wouldn't call it epilepsy. Epilepsy is typically reserved for recurrent seizures, and easily 50% of them are completely idiopathic, meaning we have no idea what's causing the seizure. So seizures are broken down into generalized seizures, where that's probably the seizure that you would think of, if you can imagine someone having a seizure. So a tonic-clonic seizure. So these are these violent spasms of the face, neck, arms, and legs, and complete loss of consciousness. And that's really what defines a generalized seizure. Loss of consciousness must be associated with it. Okay, so a patient that's having tonic-clonic movements of their arms and legs and they're unconscious is a generalized seizure. A focal seizure is just coming from one small part of the brain. So you're typically fully awake. Now, it's not voluntary. For example, your left arm is shaking and twitching and moving, but you're watching it. You're fully awake while it's happening. And a focal seizure can progress to a generalized seizure. So it could start that your left arm is twitching and flopping around, and then the focal seizure in that one part of the brain spreads to the whole brain, and it becomes a generalized seizure. So seizure disorders definitely impact a patient's quality of life. They have to think of what they're doing throughout the day to avoid danger, right? So potentially putting themselves in harm's way. For example, going for a swim by themselves, they could have a seizure. Driving, there's typically mandatory reporting if someone's had a seizure at a hospital. That needs to go to the transportation authorities of that state uh, and report that they've had a seizure and they are potentially unsafe to drive. So patients with seizures need to think of the potential of having a seizure when you really wouldn't want to have one, as I mentioned, for example, with swimming, driving, and a lot of other activities. Okay, so without medication, pharmacotherapy, recurrent seizures or epilepsy can definitely limit a patient's activity level. So whether it's at school where they're trying to concentrate and learn, recurrent seizures can really impact that. Different employments, there would be many jobs where you would be unable to work if you had recurrent seizures. And definitely the social impact, right? So uh, the fear of going out and having a seizure while with friends can affect you, and it can affect your self-esteem and lead to depressive symptoms if you have recurrent seizures. Okay, so in children or newborns with seizures, they can often be related to congenital or inherited epilepsy. So they may not have anything specifically wrong with them, but they've inherited the condition of epilepsy. In older patients that develop seizures, there's typically something wrong. So a 60-year-old that suddenly starts to have seizures, there's usually a secondary cause of the seizure. So having had a stroke, that causes a scar in the brain. That can cause a seizure. Alzheimer's, well, that's gradual damage to multiple areas of the brain. They can lead to seizures towards the end of Alzheimer's disease. Blood collections from injuries, such as a subdural hematoma, can lead to seizures. Definitely infections in the brain, such as meningitis, which is an infection of the layers around the brain, the meninges, or encephalitis, which is an infection of the brain tissue itself, can definitely activate seizures. And then brain tumors, definitely because they're irritating the brain and they can also lead to seizures. Okay, so all of these conditions and many more can lead to a secondary seizure. And they also need medications to control the seizure. So always think of the safety issues as well when someone is having recurrent seizures, and they really have to put some thought into what they can do and what they can't do safely. Okay, so just a couple of minutes on this slide. So status epilepticus is someone who's having unremitting seizure. So it's a continuous seizure for more than 5 minutes, which doesn't sound like a long time, but it is when someone's having a seizure. Or they have one seizure and it stops within a minute or so, which is usual. And then they have another one within 5 minutes. So either one of those would define status epilepticus. Uh, these are often of the general tonic-clonic seizure type. So when I'm referring to status epilepticus, sorry, and there's often aspiration of vomit, there's tongue biting, and there's very frequently incontinence of urine. So When we see that and someone comes in having had a seizure, but we're not quite sure since the seizure has stopped, when we see if that the tongue's bitten or that there's been incontinence, or even more suspicious that they had a seizure at home. So what can status epilepticus lead to? So continuous seizures for greater than 5 minutes, or two seizures within the 5 minute period. Because the vast majority of seizures stop within a minute or two. But if they continue, well, they can lead to hypoxic brain injury. So here's this brain that's discharging incredible amounts of electricity, uh, and it requires large amounts of oxygen. So they can develop hypoxic brain injury if it continues. Hypoglycemia from all the energy that's being consumed, um, not only by the brain, but by the body parts that are contracting forcefully, can lead to hypoglycemia. Hyperthermia is where, because of all the muscle activity, the patient is now becoming hyperthermic. Acidosis is the breakdown of is due to all the metabolic processes that are occurring because of all this activity, such as muscle contractions, and you make acids as a byproduct of all the muscle contractions. And also the metabolic processes lead to a metabolic acidosis. So if left untreated, status epilepticus will very likely lead to death and brain damage or death because of the above effects. Okay, what helps determine which anti-epileptic medication is used? Well, many factors come into it. The type of seizure. Uh, some medications are more effective for a specific type of seizure. So because there's a variety of different types of seizures, once the specific seizure is diagnosed, that will help determine which medication should be used. Medical history, so someone who has many other uh, conditions or is on many other drugs, that might help determine which medication because of drug interactions. The results of an EEG, which is an electroencephalogram, where they put wires all on the skull, on the scalp, to diagnose specific seizure patterns. Uh, and as I mentioned, oh, there it is again, comorbid conditions, right? So other conditions that might be impacted by the drugs that we use. The big advice that patients get is to never stop taking the medication suddenly, because that puts them at risk for sudden onset of recurrent seizures and even status epilepticus because they've completely withdrawn from the medication. On the right is showing information on what position to put a patient is in that's having recurrent seizures or is seizing and you come upon them, and I'll leave that to you. Okay, so we're going to spend a bit of time talking about some individual anticonvulsants for seizures, and you will also notice that anticonvulsants are used for other indications as well. So when a medication is created for a specific indication, over time we realize that, oh, we can use it for this disorder as well. And you might notice this as we go through some of these drugs. So phenytoin is really just used for seizures. An assortment of different seizures. And when we say epilepsy, we're just referring to recurrent seizures. And the way most of these drugs will work is that they reduce neuronal firing. They suppress the activity of the neurons and slow down the action potential, which limits the ability for a seizure to begin and then across the cortex of the brain. Okay, so what are adverse effects to phenytoin when someone has to take this for years and sometimes a lifetime, right? So phenytoin can be very sedating and fatiguing, and that makes sense. It's an anticonvulsant. It's trying to reduce and suppress neuronal firing. Okay, so you can be tired on it. You can be off balance for sure, especially when you're toxic on phenytoin, where the levels go too high in the bloodstream. And we do check phenytoin blood levels once in a while with patients that are taking it. So you can become ataxic, off balance. So ataxia is referring to uh, the, uh, the the loss of balance. Okay, and some certain medications can cause ataxia. Phenytoin is definitely one of them. Nystagmus is the shaky eye movements. When you look at someone's eyes and they're going from side to side, that's nystagmus. And with toxicity, phenytoin can also do that, as well as confusion. So you can see all these toxic effects of phenytoin are really all CNS side effects so far. Swelling of the gums in the mouth. Remember that one. That one's very common with phenytoin. Okay, so uh, you'll see in patients' mouths that the gums between the teeth will all be hyperplastic and swollen. Okay, and lastly, it can cause a bit of hair growth, so hirsutism. So some facial hair, more body hair sometimes. But I would concentrate more on those CNS adverse effects, plus the gum swelling would be very important. So, under nursing considerations, always thinking about toxicity with phenytoin, because patients can definitely become toxic and they require serum phenytoin levels once in a while to make sure that they don't become toxic. And the signs of toxicity when you're seeing these patients, so off balance, confusion, um, nystagmus, the rapid movement of the eyes back and forth unintentionally is nystagmus. And you can get serious rashes with these anticonvulsants as a group. So that's when we're going to start to discuss Stevens-Johnson syndrome. So severe rashes, think of anticonvulsants as a whole group causing potentially bad rashes. Okay, so we discussed serious rashes with an antibiotic called trimethoprim sulfamethoxazole, which is Bactrim, because of the sulfur group. So now we're talking about the same type of rash with the anticonvulsants as a group. Okay, intravenous dilantin is a slow infusion because of all these effects. Plus, it can cause hypotension when given too quickly. And a broad statement about never stopping any anticonvulsant medication if you're on it for seizures, okay? Because that can lead to resistant seizures returning as the serum levels of the anticonvulsant quickly drop. And lastly, I just want to mention that when you're looking at the traditional anti-epileptic medications, there is quite a list: phenobarbital, primidone, phenytoin, carbamazepine, valproic acid, ethosuximide. The first initial part of that chapter, where they really are referring to phenytoin. Okay, so the central nervous system effects, the toxicity of nystagmus and ataxia and respiratory depression, And then followed by gum swelling, which is really quite specific to phenytoin. And then they start to describe the intravenous rate of the medication. Again, that's for phenytoin. Okay, so that may seem confusing when you're just suddenly seeing a list of drugs and you're not quite sure which one they're referring to. But phenytoin is the one they're talking about. Okay, so phenobarbital, it's a sedative, right? It's a barbiturate sedative that we can use as an anti-seizure medication. So it's not first line, and the reason why we don't use it first line is it's so sedating, especially in children that are going to school. Very difficult to learn when you're on phenobarbital. Okay, so how does this one work? Well, it works through that inhibitory system called GABA that we've mentioned before with benzodiazepines, for example. So what are the adverse effects of phenobarbital? Well, typically it's significant sedation and depression, uh, followed by confusion. In children, they can have a bit of the opposite effect, where they're irritable and hyperactive. So remember, some drugs do the opposite in children. But very difficult for children to go to school while on phenobarbital because of its sedative properties as well. Okay, so not used very often. So again, just think of it as a group uh, of anti-epileptics that can lead to bad rashes and serious rashes. So if you see rash on a question, or ATI seems to like asking this, think of anticonvulsants as a group that can lead to significant rashes. Phenobarbital can be monitored in the bloodstream, just like phenytoin can be. And again, not stopping this medication if a child or an adult were on it. But again, because of the importance of going to school and trying to be uh, uh, able to focus at a job, phenytoin is less and less commonly used. Okay. Okay, so carbamazepine, another anti-epileptic to control a variety of different types of seizures. And we use it for a condition called trigeminal neuralgia, which is this unbelievably painful condition on one side of your face typically. And it's a nerve condition of the trigeminal nerve that supplies sensation to the face. And that nerve along its pathway, we think, gets pinched or blocked and causes severe pain to the face. They come like lightning bolts. People describe them as almost like getting a knife into the face. Very disabling. And because carbamazepine, again, has the ability to suppress neuronal firing and reduce nerve activity, it can be very effective in trigeminal neuralgia. Okay, so what are the adverse effects of carbamazepine? Definitely, like you're seeing that rash again, right? Stevens-Johnson syndrome. So anticonvulsants as a group. But Tegretol can also cause bone marrow suppression, which would be definitely one that we need to watch out for. And again, it's very sedating. Like most of them, because of how they work, they're very sedating for children and adults. So we start at low doses and slowly increase so that the body can get accustomed to the sedative effects. Okay, so what are we going to monitor? What are some nursing considerations? So definitely stopping the drug if they're if it's noted to have a severe rash in particular, or if there's signs of bone marrow suppression, right? So petechiae, purpura on the skin, indicating low platelets, fevers, low white blood cell count can be concerning, and of course signs of anemia such as weakness, fatigue, uh, orthostatic symptoms when someone stands up. Shortness of breath can be an indication of anemia. Okay, so we will check not only carbamazepine levels to make sure that uh, they're in normal range in the bloodstream, but we'll also do a CBC to make sure that the bone marrow is operating normally. What else do we talk about with carbamazepine? So again, avoiding activities that require alertness until the seizures are under good control. That's important. Avoiding grapefruit juice. So again, here's grapefruit juice that comes up in another medication, right? So as the modules go on, you'll start to see that grapefruit juice comes up, and it really just has to do with causing elevated levels of carbamazepine because it blocks its breakdown in the liver. Okay, so just a bit of information on each. There's lots and lots of information and interactions and toxicity. Keep it keep it to the simple, the 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 ones that really stand out. Okay, so valproic acid, anticonvulsant medication. It stabilizes uh, the neurons, so it's been found to be effective in bipolar disease. So, so valproic acid is often added to medications that are used to treat bipolar disease, and that's been it's been used for years for that indication. Migraine headaches, valproic acid, again, a nerve stabilizer, and it's been found to have some beneficial effects at suppressing migraine headache recurrence. So there's a couple of other ones. I think the main ones I would remember is seizures and bipolar disease. Okay, and how does it work? This one happens to use the GABA system. So there's multiple ways that anti-seizure medications can suppress seizures, whether it's directly reducing action potentials in the brain or using the GABA system to suppress uh, uh, cortical activity and the potential to develop a seizure. Adverse effects of valproic acid, definitely have to watch the liver and the pancreas. Okay, so hepatotoxicity, and it can lead to pancreatitis. Valproic acid can also lead to low platelet counts, uh, so it can lead to potential for bleeding, petechiae, and purpura on the skin. And lastly, another one that is a bit strange is that it can cause high ammonia levels in the blood, and it's through a mechanism the with its effects on amino acids. It can lead to high ammonia levels, and high ammonia levels can have CNS side effects such as confusion. Okay, so that those are the ones that I would try to remember for valproic acid. But the big one, hepatotoxicity and pancreatitis. And then as a bonus, I guess as a bonus, thrombocytopenia, so low platelets, high ammonia levels that can lead to CNS side effects such as confusion. Okay? Under contraindications, no need to mention a lot there. And under nursing care, just to know that we can do valproic acid levels, whether you're taking it for seizures or for bipolar illness, valproic acid can be checked in the blood, just like phenobarbital levels and phenytoin levels. Okay, so ethosuximide, we're not going to spend much time talking about this one. Used for seizures. In particular, it's used for absence seizures, which are these mini seizures that children get where they just blank out for a couple of seconds and then return to normal, and then they blank out, and they can do this hundreds and hundreds of times a day. So you can imagine their ability to try and learn at school when they're having 100, 200, 300 brief um, absence seizures, or what's called petit mal seizures. Okay, and that's it. I'll leave this slide. There's nothing really more to add to it. Okay, so the next one is lamotrigine. Again, this one is used for seizures, and because it's a nerve stabilizing medication, it's been found to be effective in bipolar disease, since really bipolar is a cycling of your mood related to nerve activity. So it's been found that some of these anti-seizure medications are effective in bipolar. So this one, it suppresses the GABA system. Again, it has CNS side effects, which will typically be fatigue, sleepiness, dizziness, double vision, off balance. Okay, so being aware of that, since especially older people will be at risk for falls. Aseptic meningitis is really just, there's no bacteria involved in this. I know you see the word meningitis, but it just means it can cause inflammation of the lining of the brain, and it presents with headache and stiff neck. And if that were to occur, the medication would be stopped. And then, like other anticonvulsants, you can get serious rashes with lamotrigine. Stevens-Johnson syndrome, and another one that's really in the same group as Stevens-Johnson, called TEN, toxic epidermal necrolysis. I would just group that together in Stevens-Johnson syndrome as a very serious rash. Okay, um, and I think that's all that really needs to be said for this. There's a bit more information in the book, but again, just try and see them all as just anticonvulsants. They all have slightly different side effects, um, but hopefully once you've seen them 2 or 3 times, it'll just some of it will stick. Okay, so here's another medication for seizures, relatively new actually, levetiracetam or Keppra. uh, Used more and more for control of epilepsy or seizures. And it enhances the effect of the GABA system, causing control of, or leading to control of seizures, because that's an inhibitory system. So it can lead to CNS effects, but because of that effect, right, on the GABA system. So dizziness, depressive symptoms. I'm not going to go into too much detail about this medication. There's a bit of information in the book on it. I think just knowing that it's an anticonvulsant, I think that's just a good start, because there's quite a few of these. Okay, so another one, topiramate, used in epilepsy, and can be added to migraine therapy to try and prevent the recurrence of migraines. So not to treat an acute migraine headache, but actually to take it to prevent them from coming on to begin with. Okay, I won't repeat the action because you can see it there. Um, as for most of the other ones, this one will have CNS side effects because it's suppressing the brain. So somnolence and dizziness and ataxia. There is potential for reduced sweating and increased body temperature. I would tell you that's relatively rare. Um, there is potential for metabolic acidosis with this medication. If that were to happen, we would definitely stop the medication. This would be relatively rare as well. And angle closure glaucoma is also mentioned. Not a very common effect of this medication. So if I was to take away anything from these anti-seizure medications, yes, there's some that cause hepatotoxicity, such as valproic acid. Yes, there's some that cause bone marrow suppression, such as carbamazepine, but they all have CNS side effects as one of their primary uh, adverse effects, and they all can lead to nasty rashes such as Stevens-Johnson syndrome. So, got to categorize them a bit and just take the big side effects, because otherwise it becomes just a bunch of confusing side effects that don't seem to match. Um, it just starts to get all confusing. Okay, so categorize the big side effects. Avoiding with other CNS depressants. I'm sure by now it's starting to make sense why you would avoid a medication that is already sedating with other CNS depressants. Okay, so this next medication, oxcarbazepine, not a common anticonvulsant that we see in the general population. I'm not going to spend any time on this slide. It's in your booklet as well. So just a big picture view. Try and keep that. So it's an anticonvulsant. Look at the main adverse effects. Bad rashes, right? Stevens-Johnson, toxic epidermal necrolysis is a variant of Stevens-Johnson. So, and of course, using anticonvulsants can be very sedating, so avoiding other sedating medications. And I think that's all I'm going to say about this medication. It's not a common one at all. Okay, so gabapentin has been out for probably 30 years now. And originally it was used for, or is still used, for epilepsy and seizures. But it's really taken on uh, more use with diabetic neuropathy, which is the painful legs and numb legs that patients get with diabetes. And why do they get pins and needles in their legs and painful legs? Is because the little tiny capillaries, the blood vessels that are feeding these nerves in the legs, are becoming occluded, and they get ischemic loss of nerves, and they get a peripheral neuropathy called diabetic neuropathy. Okay, so because gabapentin is a nerve modulator, so it suppresses the nervous system, it has been shown to be effective in trying to settle down the neuropathy of diabetes. And the same goes for the next condition, restless leg syndrome, which we know is a nervous system where it's the sensation typically at night where you just can't settle down your legs. They're constantly moving, or the sensation of movement of your legs, and it can lead to significant insomnia, since your brain feels like your legs constantly need to move. And people can be up all night with this kind of pacing and walking around because they just can't settle down. So gabapentin can be used for that. Like other anticonvulsants in this talk, gabapentin is sedating. It can lead to dizziness, ataxia, which is off balance, and fatigue. Nystagmus, which is that abnormal eye movement back and forth, unintentional. And finally, it can definitely lead to some weight gain and peripheral edema. Okay? So that I think that's all I'm going to say on gabapentin. That really it is categorized as an anti-seizure medication, but also know that it has other uses as well. Okay, so the next medication is pregabalin, which is Lyrica. And Lyrica, sorry, pregabalin is a medication that its intended initial indication what is seizures or epilepsy. And now, after it's been used for years, it's also been discovered that it can be used for neuropathic pain. So neuropathic pain such as diabetic neuropathy, um, where, as I mentioned before, you have painful, numb legs. There's many other neuropathies as well. So sciatica, which is a pinched nerve in your back that goes down your leg. So Lyrica or gabapentin can be used for that to try and modulate the pain that's coming from the nerve. Okay, so it makes a bit of sense since it suppresses uh, the nervous system that it would have been tried for neuropathic type pain, and it's been shown to have some effectiveness. Okay, and the same will go for restless leg syndrome, where it tries to settle down the nervous system, which is responsible for the sensation of restless legs. As well, it's also used in a soft tissue disorder that typically has painful trigger points called fibromyalgia. The action I won't go into. It's through the GABA system. Adverse effects of pregabalin, yeah, mainly CNS, so somnolence, dizziness, difficulty concentrating, so cognitive effects can lead to confusion, blurry vision. And another one that's quite common with pregabalin is weight gain and peripheral edema or swelling. And that can lead to having to stop the medication because of all the weight gain and edema. Okay, so we'll move on from this medication. Okay, so last slide for this module, and let's just review this last part because I know there were a lot of drugs in the anticonvulsant group, and I think if you remember uh, that each drug has some specific adverse effects to it. So when I think of phenytoin, I think of gum swelling. Plus, of course, the potential for a serious rash. When I think of carbamazepine, I think of bone marrow suppression and Stevens-Johnson syndrome, a bad rash. When I think of valproic acid, I think of hepatitis and requiring to check serum levels of valproic acid, or in fact, carbamazepine or phenytoin. We check blood levels. Okay. And the overriding side effects or adverse effects of this group are going to be central nervous system side effects because that's where they're basically working. So fatigue, somnolence, dizziness, ataxia, it's going to be a theme through all of them. And as a group, they tend to cause potentially serious rashes. So So those are two adverse effects that you can add to most of them. And then each individual one may have a specific adverse effect or maybe two that would be good to keep in mind. Okay, so the other thing to remember is these are often lifetime medications. Sometimes patients do attempt to slowly taper off anticonvulsants with their healthcare provider. But for the most part, these are lifelong medications to control their seizures. Advising patients on avoiding risky activity. Uh, due to the potential of having a seizure. So that's whether that's being up in a tree with a chainsaw on a ladder, or whether that's swimming across a lake, or operating heavy machinery because of the medication in that circumstance, which is very sedating. So patients can be injured significantly by having a seizure at a inopportune time where they can fall or drown. So that's always good to discuss with the patient. Okay, so this is the end of this module. I know it's longer than usual. I'm trying to keep them to about 2.5 hours, and this one's gone beyond even an extra hour. There just happens to be a lot of information with anti-anxiety medications, antidepressants, and just to get a bit of background before even starting the medication. So I think that'll help you going forward so that uh, the medications can fit somewhere in your brain as opposed to just seeing medications in isolation. Uh, so see you at the next module. I hope you're getting benefit from these voiceovers.